So this was so this was an AI module which used various parameters like biopsy features, colposcopy features, and all the risk factors normally attributed to cervical cancer to predict the risk whether a woman is likely to develop cervical cancer or not. Artificial intelligence can also help in automated cytology. That means the module itself is reading the cytology or the pap smear rather than the cytologist. So this was a study where they found that the artificial intelligence was able to actually detect more number of CIN2s, almost by 6% than the skilled cytologists also. Another study found that in the detection of CIN2, AI fared much better than the doctors who were not so skilled. Although the skilled cytologists were slightly less performing as compared to AI, the difference was not that significant. But when compared to doctors who did not have any skills in colposcopy, we found that the artificial intelligence tended to fare much better. So artificial intelligence can be used to train doctors in the periphery, to help doctors in the periphery who may not be skilled colposcopists to better predict CIN2 so that our treatment is streamlined. AI can also be used to detect on colposcopy what is the area of interest and also to guide which areas to take the biopsy from. In fact, now we have moved from big bulky colposcopes to smart colposcopes. So this is one model which we used in our hospital also. This is called EVA colposcope. It is like a smartphone which can be carried even to periphery and for camps. And we found that the detection rates of CIN2 and above were equal as compared to the standard colposcopy at much lesser cost. In fact, even your own ordinary smartphone can be used to capture images. And there are studies which have shown that a standard smartphone can predict with a reasonably high degree of accuracy CIN2 and above. Artificial intelligence, like I said in radiomics, has been used to predict lymph node metastasis. So I have presented two cases. On the left side, there is a patient who had a low grade 1 squamous cell carcinoma with a lymph node which was sub-centimeter in size. But the algorithm found that this was actually positive, and this actually turned out to be positive even on the histopathological after the surgery. As compared to the case on the right, where there was a false positive as on the MRI, but the artificial intelligence was able to accurately predict that this was actually a true negative lymph node. The PET-CT slices can also be used to predict the rates of local relapse and distant metastasis in cervical cancer. In endometrial cancer, artificial intelligence has been used to detect endometrial intraepithelial neoplasia and endometrial cancer using risk models, of which endometrial thickness, age of the patient, and BMI are most important. It can also be used to streamline hysteroscopy images. So a large number of hysteroscopy images were run through AI algorithms, and a program was developed to help any person who's not so skilled to use artificial intelligence to detect whether the hysteroscopy, the image we are seeing, is normal or likely to be abnormal. And this can help in doctors who are not so skilled in this. Artificial intelligence can accurately predict myometrial invasion, especially when the tumor size of the endometrial lesion is more than 2 centimeters, as compared to even the radiologist. This sensitivity was higher with the AI. And MRI-based radiomics can predict lymph node metastasis. It can also generate something known as radiomic prognostic index. So this is a radiomic index which includes texture features of MRI images, and a high RPI was associated with poor survival, and also a high RPI had an association with certain genetic patterns. So the genes were differentially expressed in patients who had a high RPI versus patients who had a low RPI. So in future, possibly radiomics may be able to help us in predicting which genes are likely to be mutated in particular patients. And this information, if we know preoperatively, can help us in tailor the management of such patients. This is also a similar study which studied the patterns of endometrial lesion to detect whether this was likely to have a better survival or a poorer survival. You can clearly see the difference in the left side and the right side image. Left side is a low grade cancer which is not infiltrating the myometrium. The radiomic picture of that is quite different from another tumor where it is infiltrating, and this tumor was found to have positive LVSI. So a radiomic picture can help us to detect positive LVSI pre-operatively as well, because this is information which we generally get after the surgery has been done. So like I said, in future, radiomics or particular features on the MRI can be used to predict which genes are likely to be altered in a particular patient. And this, when combined with the current knowledge of histology, of the molecular classification, can be used to tailor the treatment for such patients. An example being this radiomics nomogram, which basically assessed whether this patient is likely to be a high risk disease or a low risk disease based on the radiomic score, presence of metabolic syndrome, and other factors which are mentioned here. So AI can also be used to assess whether a chemotherapy will benefit a stage 1A papillary serous cancers and also predict survivals in them. Now coming to LMS, many times we present, the patient presents with fibroids with particular features, and it may be not possible pre-operatively to distinguish between them, although we have studies assessing contrast enhanced MRI, LDH, and other clinical parameters for the same. So this group again developed an AI model, which with the help of clinical information and certain radiomics feature was able to detect with a very high degree of accuracy pre-operatively whether this uterine lesion was likely to be an LMS or a variation of a fibroid. In ovarian cancers, the biggest problem we have now is that most patients are detected in advanced stage, and we cannot detect the patient early to affect the survival rates. So these are certain studies which are going on using circulating cell-free DNA to accurately detect ovarian cancer in early cases. There is also a study which studied serum glycopeptide levels along with CA125 and HE4, which we commonly use to diagnose early stage ovarian cancer. You can see the rightmost side of the screen, the pattern, the black and white pattern of an endometrial ovarian cancer is very different from that of a non-epithelial ovarian cancer. So when we combine this with CA125 and HE4 patterns and superimpose them, the patterns which epithelial ovarian cancers are producing are quite different from benign conditions. And this can be used to detect early ovarian cancers and also to distinguish cancers from benign conditions. We all know CA125 can be inaccurate in up to 50% cases of early ovarian cancers. This study found that CA125 levels can vary postprandially. So after postprandial, if the increment of CA125 was more than 10% and fasting CA125 was more than 20 units per ml, this combined with an algorithm was able to predict with the highest level of sensitivity the early ovarian cancer. And this was much better than randomly advising CA125. So a combination of fasting CA125 and incremental rise in CA125 were more than 10%, and using this algorithm was a better predictor of early diagnosis of ovarian cancer. Many times the patient comes to a gynecologist and the first imaging we do is an ultrasound. Although there are other models available, this is a very easy model which is available. This is called Trace 4OC. When the gynecologist does an ultrasound, she loads her ultrasound image. This image is then scanned by this algorithm. The algorithm asks certain questions, whether the patient is postmenopausal, what is the level of CA125. And after scanning this online, it tells you what is the risk of malignancy. So this patient had a medium risk of malignancy, and this helps in referring this patient to a gynaecologist. Obviously, we know there are many models which have predicted complete cytoreduction based on different scores. Secondary cytoreduction is much in vogue these days, whether we should do or not. So this AI model basically predicted that disease-free interval and the presence of retroperitoneal recurrence were actually the most important factors which predicted complete cytoreduction at secondary cytoreduction. In fact, lower down, if you see, carcinomatosis or multiple peritoneal disease was lower down. It was of lesser importance than the disease-free interval. Very interesting. the histopathological images. So the histopathological image of a high risk group of ovarian cancer will vary from a low risk group. So what AI does is it segments these images and it catches certain features of high risk group versus low risk group. So the model actually predicts on the basis of histopathological image whether this is likely to be a high risk or a low risk group. Last, radiation AI has also been used in radiation oncology and more recently in adaptive radiotherapy. What happens when we give the patient external radiation is that the tumor starts shrinking. So our target volume also keeps changing. That is why it is important to repeatedly do a calibration so that it is according to the current tumor size. So if this is done manually, this takes a lot of time. When we use artificial intelligence, it is done by the machine, checked by the physician, and then this makes the process much easy and faster. So in conclusion, where do we stand on terms of AI, especially AI in gynae oncology? So we know that AI can increase the efficiency of healthcare delivery by reducing the cognitive burden on human experts, basically because it can process a large volume of information which we as humans cannot. It is superior to less experienced clinicians. We saw that the accuracy of AI in cytology, in diagnosis of CIN2 was better than the gynecologists or the doctors who were not trained, who were not skilled colposcopists. So there, this AI can help these doctors to accurately diagnose CIN2 and above with the help of AI. We need to understand that AI cannot take over healthcare, but AI can assist and make a hybrid system to take us forward. Ultimately, it will be the medical professionals who will be the real evaluators of diagnostic and therapeutic performance. Most importantly, AI cannot replace the humanness of the medical profession. It cannot replace the sympathetic characteristics of human doctors. There are also privacy issues at play because when we are taking a lot of patient data and putting it into algorithm, we need to be aware of the privacy issues. Most importantly, AI algorithms, for example, WFO or other algorithms, they need to be adopted to different regions and different ethnic groups. What works in US may not work in India or any other country. So we need to develop our own AI models because our racial profile is different, our genomic profile is different, and therefore our AI models have to be different from those in the West. Ultimately, AI is a tool, not a crutch. So where do we stand in the future? AI can take over our jobs in some cases, at least, we don't know, possibly. And the same AI may help us in therapy after losing those jobs, rubbing salt in the wounds. What will happen? Let's see. The future looks interesting. Thank you.
Yeah, thank you. Neha, I'm so glad that we are a part of this webinar. And I think Dr. Rupinder will say a few words. I just want to share my thoughts on Watson because Apollo has Watson, and
Yes.
it was
Up.
very difficult to put everything because they need very specific answers, and sometimes those specific answers are not there in our reports. So
Correct.
it's very difficult and time consuming. We had to keep a separate person who can actually put all these things
Yes.
into that, and then the
Actually,
results comes
yes.
like as per this trial she should get this, and then the drug is not available in India or like something or the other
Yes.
thing, so that
Yes.
it is
And I'll
it
tell
did
you
not work.
something interesting. I'll tell you something interesting. The WFO was actually built in collaboration with MSKCC. After a year, they realized that it was not working, and MD Anderson bought it. MD Anderson also left it. So now WFO is actually expanding and using this in other countries. There have been studies in China. There have been one study. In fact, Dr. Somshekhar has also done one study, but they have found varying levels of accuracy. The disagreement rates were high, especially in cervical cancers. In some, like endometrial cancers, the concordance was more. But yeah, you are right. You know, it requires a lot of effort to actually put in. So maybe not this model. The future is that an adaptation of this model, especially a model which is specifically suited to India. You know, we cannot replicate
Yes,
a
that is
Western
true.
model to an Indian population characteristics.
So Neha, that was an absolutely an excellent talk.
Thank you.
I don't know, can you see me?
Yes, ma'am, we can see you.
Okay, but I'm just seeing that my image is stationary.
You're visible, ma'am.
Okay, fine. So anyhow, your talk, of course, was absolutely excellent. And like what I had, there was a group of people sitting and they were discussing about AI and about how their jobs were in danger because of AI. And then one person said, he says that, see, my job is not in danger at all. So the others asked him why. He says, because my job doesn't require any intelligence as it is. So you see, that is how, it's, kind of working out. We don't really know how far we are with the AI and, exactly how is it going to affect us as far as, all of this is concerned.
Yes. So the idea is to incorporate AI to help us.
Yeah. So I mean, it's nice to know. It's nice to know that it can predict all your lymphatic involvement and depth of invasion and various other characteristics very well.
Yes. What was interesting for me
are reliability and everything is still disputed. We don't really know. How much
they need to be validated because most of these studies have been on smaller subset. But what was interesting was using the histopathological images and the radiological images to actually predict what the genomic patterns will be. Although this is still in nascent stage, just imagining that when this is refined, if we are able to predict genomic patterns, that would be something very interesting.
Yeah, that's right. Are there any questions in the chat box, or is there anybody else asking anything? Shall we see? So I don't see any questions in the chat box. And I think in the interest of time, you've left a lot of thoughts in our minds, but I think we'll just move on. Thank you so much for having me here.
Thank you.
So moving on to this next session, adjuvant treatment in low-grade ovarian cancers, what, why, and when. Let us hear from the experts themselves. I would invite our speaker, Dr. Jaya Ghosh, who's a senior consultant and professor in medical oncology at Tata Memorial Center. We welcome you, ma'am. I hope you're there. You have joined in. I can see.
Yes. Good evening, all. I tried sharing my.
Yeah. I'll just stop after introducing the speakers, ma'am, and then you will be able to share your slides. Okay. Yeah. I would invite the chairpersons for the session, Dr. Asima Mukhopadhyay. Good evening, ma'am. She is the founder and director of Kolkata Gynaecological Oncology Trials and Translational Research Group, and is presently a consultant gynae-onco at James Cook University Hospital in Northern Cancer Alliance, UK. Good evening, ma'am. We welcome you to this session. You have joined, ma'am. Hello.
Nidhi, can you see whether Dr. Asima is in the attendees? Yeah, I'm also having a look. Meanwhile, I think you can invite Dr. Bishwajit.
I invite Dr. Bishwajit Dash. He is an associate professor and surgeon at Tata Memorial Center and an executive committee member at GOI. Welcome, Dr. Bishwajit. And just check about Dr. Asima Mukhopadhyay. We'll start with the session.
She's not there in attendees.
Okay. So over to you, Dr. Jaya, ma'am. I would just stop my sharing and you can start with your screen sharing. Yeah.
Yeah. Ba. Ba, 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 ba.
Sorry, can you see my screen?
Yes, ma'am, we can see your screen.
You can hear me also, right?
Yes. Please carry on.
Okay. Thank you, Neha, for giving me this topic. And I think I had to really go back and look it up. And so I'll just, I think the whole topic discussion was adjuvant treatment in low-grade ovarian cancers, what, when, and how. So I think to this audience, one second, why is it not holding here? I don't need to say that, ovarian
cancer. Ma'am, you can just make it full screen if you can.
Just 1 second.
Yeah.
Is that okay?
Yes.
Okay. So I think to this audience, I don't need to tell them that, ovarian cancer is not one disease. And although a large majority of ovarian cancers are high-grade serous and which are the main pathway where is BRCA mutation or BRCA-NES. The type 1 cancers, they have a completely different pathway for development. And amongst these type 1 cancers, we have these low-grade serous cancers, which are mainly driven by the KRAS, BRAF, B2 and the PIK3CA mutation pathways. So we know that, these low-grade serous do not turn into high-grade serous. The high-grade serous and the low-grade serous, they generally have a completely different pathway for development. And usually, of course, there's nothing never in oncology. The low grades do not turn into high-grade serous. So as I said, that the pathway alteration in low-grade serous and, the BRAF, MEK, ERK pathways, these are the main pathways which are involved. And why it is important, because today, at least in the recurrent setting, we are looking at MEK inhibitors. And similarly, we know that the PI3K, AKT, mTOR pathway is also involved. And similar to something in like breast cancer, we are looking at mTOR inhibitors in these patients. And so how is the low grade and the high grade serous cancers different? Of course, they're developmentally different and they of course look different. And importantly, the estrogen receptor expression, if you see, it is almost 60% in low grade as compared to only 27, one can remember 30% and 60%. So it's almost 60% of these tumors express ER, and as we shall see, that has an implication in the treatment and how we treat these patients. Another important is the expression of the P53 expression. Of course, we all know that high-grade serous carcinomas are characterized by P53 mutant status, whereas the low-grade serous, we have the wild-type P53. And this is just to demonstrate that, the stark estrogen staining in the low grade as compared to the high grade. So, I mean, that of course is the intensity of staining and the number of cells, which is higher in the low grade as compared to high grade. And similarly, this diffuse P53 staining, which signifies the mutant one in high grade, whereas, usually the cutoff taken is around 70% to say that it is diffuse staining. So to define mutant or no staining, null type staining. Whereas in the low grade, we know we have this patchy staining, which kind of defines these low grade tumors. And as we all know that the median age of these patients is younger, the median age is around 43. So low grade comes at a little younger age as compared to higher grade. And unlike high-grade ovarian cancers, fortunately here, the survival is around 80% overall, 81 months of overall survival and 20 months of PFS. And the most important predictive factor was the presence of disease after primary cytoreduction. So I think optimal cytoreductions and, surgeons kind of play the key role in achieving probably are the most important predictive factor in survival for these patients. And another important thing, which is similar. So, there is some thought that these low-grade serous ovarian cancers behave more like these hormone-positive breast cancers. And we know, patients who are younger than 35 years of age, we know low-grade serous cancers have a good prognosis. And remember that in that study where we had looked at these survival outcomes are with the use of platinum-based chemotherapy. So another important thing is that, patients who are less than 35 years of age, their outcome is significantly worse as compared to the outcome of patients who are more than 35 years of age. And this is something similar in hormone-positive breast cancers as well, where, younger hormone-positive breast cancers have a worse outcome, less than 35 years have a worse outcomes as compared to the older women. And something similar pans out. Although I think you should look at, this is 200 months. So that's close to 10 years. And this is 400 months. So like close to almost 20 years survival. So I think that is something which is important to know. And as I previously said that, both low-grade and high-grade serous cancers, it is optimal cytoreduction which plays the most important part. And of course, once we achieve an optimal cytoreduction, I mean, amongst the low and high grade, of course, low grades would fare much better as compared to a high grade serous carcinoma. So, of course, then what is the response rate to chemotherapy in these patients? Of course, so So I think where we can definitely safely omit chemotherapy is a 1A low grade and 1B low grade. 1C2 and 1C3 are, I think, gray areas. And if, especially if the patient is younger than 35 years of age, we would consider adjuvant chemotherapy for these patients. So the next thing is the role of hormone therapy. And we know that the role of adjuvant hormone therapy, this is a retrospective study. And the role of adjuvant hormone therapy after chemotherapy showed that improvement in median PFS from almost 26 to 65 months, and improved even though the improvement in OS was not so significant, probably because many of these patients also received hormone at progression. So therefore, it is included in the NCCN recommendation category 2B. So all the data on maintenance hormone therapy is currently from retrospective studies. So I think there are two ongoing studies on the role of adjuvant hormone therapy. And one is this Matau study, where patients with stage 2 to stage 4 in fact, they also included low and high grade serous and endometrioid, and they have checked that if ER is positive, they have planned to screen them and randomize them to letrozole versus placebo. And of course, as we know, in high grade serous, they could receive bevacizumab or PAR. And another very interesting is this NRG study, where in fact stage 2 to 4, because we know that chemotherapy, they're not so chemo responsive. So do we need any chemotherapy at all? And probably that is the question that they seek to answer. And this is paclitaxel followed by letrozole versus letrozole alone. So that is omitting the chemotherapy backbone altogether. And we have a similar phase 2 study ongoing at TMH. Dr. Seema is leading that protocol. And there are another important, as I said, that we are today looking at low-grade serous as something like hormone-positive breast cancer. And this was a pilot study of around 15 patients, where fulvestrant combined with a CDK4/6 inhibitors was used. And in that study, the abstract was presented at ASCO in 22. And the clinical benefit rate was around 80%, where around half of them had a partial response. 47% of these patients had a partial response, and around 33 had stable disease. About 20% or 1/5 of them progressed on therapy. So I think this is important, because if you remember that with the use of neoadjuvant chemotherapy, the response rates were only around 20%. And I think we need to really look at the full text and further data evolving with the use of neoadjuvant hormone. I think on lines similar to what we do in breast cancer, where hormone positive cancers is treated with and so I think this is in lines of that. And of course, CDK4/6 inhibitors are associated with chemotherapy, yet and even if they do develop neutropenia, the rate of development of febrile neutropenia or mucositis is less common with the use of CDK4/6 as compared to chemotherapy. And with this particular CDK4/6, another important side effect is diarrhea. So I think this is a proof of concept, and it needs to be further established in future studies as to how to take it. So I think my take-home message would be identify low-grade serous. And why I would say identify low-grade serous is because especially in patients with advanced ovarian cancers, when they do not respond to neoadjuvant chemotherapy, especially if initially we had only a cytology, it is important to stop biopsy and check if it is a low-grade serous. And this is especially true if it is a young patient who, even though she's not responded to chemotherapy, still is ECOG 1 and 2 and has ascites. So those are the patients where we really need to suspect, because these patients would do very well if they are taken up for surgery and put on adjuvant hormones. So I think important is to suspect low grade, especially in patients with advanced cancers whom initially we give neoadjuvant chemotherapy. Optimal cytoreduction is the key. And of course, in stage 2 to 4, definitely adjuvant chemotherapy with presently paclitaxel and carboplatin. Of course, when we do await results whether we can omit chemotherapy, but presently that is still the standard of care. And even though presently the data is from retrospective studies, it is still a stage two. I mean, it's a grade 2B recommendation to use letrozole in these patients with which has shown a significant improvement in PFS and OS. And of course, we await the data from prospective randomized studies. So that's it. I think there is hope in the limelight. Thank you.
So there are a few questions from the chat box. When we see a poor response to neoadjuvant chemo in stage 3 low-grade ovary, should dose-dense regimen be contemplated or should surgery be preferred? What are the second-line options where the first line fails and the surgery is not feasible?
Okay, so I think what is important is that if we see that the patient has had a poor response to neoadjuvant chemotherapy, I don't think dose dense would help, and if she can be taken up for upfront cytoreduction, that is what should be used. And can we? Okay. Should I go? Okay, should I go question wise from the chat box, Neha?
No, ma'am, we'll do that for you. We'll do that for you.
Okay.
Yeah.
I think Dr. Priyanka, your this thing was answered. I think that pilot study on fulvestrant and CDK inhibitor, if we that showed a good response, we don't know whether in future, if in advanced low grade, C ovary, if that goes forward, we could possibly use that. But as of now, yes, surgery is the first line.
Yeah, and in case surgery is absolutely not, I mean, I think every attempt should be made for surgery, but if it is absolutely not feasible or extremely morbid, and what we presently also do is to put them on just hormone therapy, just
Yes.
them on leuprolide and letrozole. And of course, I think we need to audit that data, but some of them do show a response if they've not responded to chemotherapy. Presently, that's what we do if they have not responded to chemo, and surgery is not feasible anyhow. So
And ma'am, what is your experience with BEV and PARP inhibitors in this subset? Have you ever used them, and what, if so, what has the response been with bevacizumab or PARP inhibitors?
No, I have never used bevacizumab in low-grade serous, but of course, I think there is data for BEV, especially in the recurrent setting. But I'm not, but there's a very limited data. So I think BEV is really not something that one thinks of as a first line. In the recurrent setting, we have different hormone therapies that can be used, and they do respond to the hormone therapy. With respect to PARP inhibitors, most of the studies of PARP inhibitors in maintenance and recurrent setting have been with the use of high serous
Yes.
as I said, that low grade is BRCA. Having said that, I think the percentage of low, I think close to 2% only. One need to check the exact percentage. So once they are not BRCA driven, so I mean that's the main difference between the low grade and the high grade. So I think that is the reason why we wouldn't expect a response to PARP. Although there are, I think, some ongoing studies of PARP in low grade who are BRCA mutant.
Okay.
Certainly no for a short,
Yes.
in short, no for Bev and PARP.
Okay.
Yeah.
So, ma'am, there are lots of questions in the question box. So, what is your opinion on MITO 22 trial?
Okay. I Sorry. Okay. I think I may not have updated myself on the MITO 22. So this is. This-
Okay, we can come back to that question again, ma'am. Role of tamoxifen in low-grade ovarian cancers.
Yes, so both letrozole and tamoxifen have been used, although in the present, if you look at the retrospective studies, even tamoxifen has been used. But in most of the present prospective studies, letrozole is being taken forward. And I mean, the only rationale that I can think of is probably because taking cue from breast cancers, letrozole has shown a greater response.
Yes. What are the options available for patient having DVT in stable disease, low-grade ovarian cancers in recurrent settings?
Again, if they have DVT, we can use the letrozole, because that DVT is a contraint. Letrozole can be used because we can't use tamoxifen, but
Correct.
that
Yeah.
is
Right. Stage 1C hormonal treatment or chemo. I think it is a cause of debate. Any answers to
for
that?
observation only also.
Yes. Okay.
Sorry.
So Dr. Anju has asked, does chemotherapy also alter the histology of primary tumor?
I think we don't know that. So I think it was whether there is any change, or we know that, that for that matter, even in high grade serous, whether some other pathways are activated, whether they become more chemo resistant. That is something like.
Right. Okay. So role of leuprolide and letrozole together, I think you did answer that. Somebody wants to know the role. And another question is, what is the dose?
So leuprolide, I would only use that if we are using it in the neoadjuvant setting in a premenopausal lady, because if she's already if post surgery, then of course we don't use leuprolide. If it is pre-surgery, then we do use leuprolide, and that is you usually use a monthly dose of leuprolide of 3.75 mg once a month, mainly because it, at least in breast cancers, some of the studies have shown that it is able to achieve a better control, having better suppression of E2 FSH, but even the 3 monthly can be used, but monthly may be preferred along with letrozole. Yeah.
Okay, ma'am. Can we start letrozole along with chemo? Say a low-grade ovarian cancer has undergone cytoreduction and we have started them on adjuvant chemo. Can letrozole be started along with that, or does it need to be started after the chemotherapy is over?
Present data is for starting them after the chemotherapy is over.
Similar to breast, yes.
Yeah, I mean,
Any reason for that though?
I mean,
why can't we combine it? Why can't we use it with chemotherapy?
I think that is a question which we have an ongoing study in breast cancer, at least in TMH. And the reason for that is also coming from breast cancer, where they thought that, once we, and that was more with tamoxifen rather than letrozole. And the reason was that, tamoxifen causes these cells to move into more like G0 sleepy phase.
Okay.
And where chemotherapy will not act.
Right.
But, that is only one study, and presently, actually, we have an ongoing study in TMH in breast DMG, where they are looking at hormone and chemo together. But till we have the answers to those, I think the present standard is to give chemo followed by hormones, or hormone alone rather.
Okay, ma'am. Any role of genetic testing if in low grade serous? Should we do genetic testing or not?
I think we should do genetic testing for these patients because that is not, except I think for mucinous we should yeah.
Any role of HIPEC according to you?
Well,
There are some
maybe,
retrospective studies.
of course, I think no, because they are so not chemosensitive. So then why giving hot chemo inside? I don't think will make it
Correct.
more
So
sensitive.
there's a school of thought that if they are less chemosensitive, if you have to give chemo, might as well give intraperitoneal than intravenous, because we don't know whether chemo will actually work. But yes, it is debatable. I see Dr. Bishwajit is now online. Dr. Bishwajit, if you want any question. In fact, Dr. Bishwajit had also conducted a survey amongst all doctors, and he has some experience in publications with this regard. So over to you, Dr. Bishwajit. Any questions from your end?
Thank thank you, Dr. Neha. I think Dr. Jaya brilliantly summed up all the things, and you have summed up the questions that could arise out of this. Hello. I think the take-home message is what Dr. Jaya told. The role of adjuvant chemotherapy, what practically we use, the chemotherapy we give in the adjuvant setting in those cases where neoadjuvant had there some response to neoadjuvant chemotherapy. I think in those cases we used to complete the chemo cycles post-operatively, and of course there is a maintenance tamoxifen or letrozole that is being used, and letrozole is preferred. We should not forget to use calcium or bisphosphonates with it, because you have to do a bone mineral density study routinely. And I think in recurrent settings, usually practically what we do is, once you have started with the hormone, in recurrent settings, if there is a prior response to chemotherapy in the neoadjuvant, or patient has received as a primary therapy and there is some response, the rechallenge or they change, they do a change of hormones. I think if they started with letrozole, they change to tamoxifen, although there are no robust studies why it is being done, but we have seen that is being commonly in practice. And BEC inhibitors, I think it's not yet available, and they are proven. And as you told, CDK inhibitors, there is ongoing research. BEV, there are some studies which show BEV as a role. There are some response, 40-50% response to BEV in some of the studies. And I think overall, it should be recognized as a separate entity, separate from high-grade serous, because they behave differently. And I think further research will show what exactly we need to do for those cancers. Thank you.
Thank you. Thank you so much, Dr. Jaya and Dr. Bishwajit, and thank you all the attendees for your questions. We now move over to our session, Two Sides of the Coin. So two sides of the coin, basically we are discussing all the aspects of a particular topic, not really debating a particular topic, but actually discussing all the aspects of it. So I would just invite Dr. Pancham to please introduce our chairpersons for this session.
Yeah, thank you. I would invite the chairperson, Dr. Rama Joshi ma'am, who is Principal Director and Head of the Department Gynae Onco and Robotic Surgery at Fortis Memorial Research Institute in Gurugram. Welcome, ma'am.
Thank you.
My screen is not moving. Yeah. I would like to invite Dr. Vijay Ahuja, sir. He is an immediate past president of GOI India, editor Indian Journal of Gynae Onco, and presently a senior advisor Gynae Onco at Astra Hospitals Bengaluru cluster. He is a cluster head of academics at Astra International Institute, Bangalore. Welcome, sir. I would also like to invite Dr. Yuri Bafna, sir, who is presently the head of the Department Gynae Onco at BM Jain Hospital, Bangalore. A warm welcome to you, sir. And welcome Dr. Kanika Gupta, who is presently senior consultant in Gynae Oncology at Max Hospitals. We welcome you, ma'am. And I invite our first speaker for the day, Dr. Seema Singhal, ma'am, who is an additional professor presently at the Department of Obstetrics and Gynecology at AIIMS, Delhi. She'll be talking about new staging of endometrial cancer, the need of the hour. And after that, Dr. Satinder Kaur will be introducing about the new staging of endometrial cancer. Do we all agree? So over to you, Dr. Seema Singhal, ma'am.
Thank you, Pancham. Before I start, I would like to thank Dr. Neha for giving us this wonderful opportunity to be part of this excellent academic feast. And is my screen visible?
Yes, Dr. Seema, we can
Yeah.
see and hear you.
Just a second. I'll just arrange the thing. Yeah. Yeah. I'm not able to convert it into a slideshow. Wait. It's not converted into the slideshow. I don't know why it is not. I can't see that icon. Okay. Shall I start without wasting time? I mean, it's taking long otherwise.
I think better we can start.
Yeah.
Yes, sir. As we all know that cancer staging systems, they are not static and they need to be periodically revised and modified whenever there is enough data to inform advancements in treatment strategies, protocols, and the outcome with regard to that particular cancer. So they are really, and that's what we have seen in last 2 years. We have changed cervical cancer and vulvar cancer staging based on the accumulation of new data. And endometrial cancer is a simple cancer to treat, but then it is the most heterogeneous, and I say one of the most difficult cancers to manage. And in the last decade, there are a lot of changes in this particular cancer with respect to diagnostics and therapeutics. If we come to diagnostics, advent of IHC, advent of molecular markers, molecular genetics, these things have led to a lot of changes in the diagnostics. And apart from that, regarding the surgical management, advent of minimally invasive surgeries, sentinel node procedures, role of advanced immune checkpoint inhibitors in the management, adverse identification of more precise identification of prognostic factors like myometrial invasion, substantial LVSI, grading of the disease, all these things have led to significant changes in our management. So probably that has led to investigators to think that, yes, is it the right time to change the endometrial cancer staging now? If you look into the 2009 staging, is predominantly based on anatomical extent of the tumor and does not take into account several other parameters which are prognostically important. What are these parameters? We'll just have a look and we'll go briefly about the staging. So first is histopathology. As we all know, that 2009 FIGO staging classification does not take into account the histopathological subtypes. So, but we know that the type 1 and type 2 tumors, they behave totally differently with respect to their epidemiology, molecular alterations, clinical behavior, and prognosis. We know that type 1 tumors, the superficial invasion is present in only 70% cases, and deep in, in the type 2, most of them are present with deep invasion, and overall survival and everything is different in these tumors. In fact, histopathology is also considered by the TCGA Research Network report on endometrial cancer, and they have tried to correlate that, yes, at a pole mutation, they are associated with the presence of high-grade endometrioid carcinomas. The hypermutated type and the low copy number alterations, they are associated predominantly with endometrioid only, and the high copy number types associated with high-grade endometrioid or serous or other mixed carcinomas. So histopathology needs a proper consideration when we stage the disease. Now the next is tumor grade and myometrial invasion. Currently, in the current system, we use three grades, grade 1, grade 2, and grade 3. But if we see, then grade 1 and 2, they behave same ways. So they are called as low grade and they behave similarly. On the other hand, the grade 3 tumors, they are called high grade tumors, and other non-endometrioid tumors also. They are the high grade tumors and they behave very differently. So do we need three grade system, or the binary grade system is enough? Apart from that, the myometrial invasion in combination with other histopathological subtypes and grade to define substagings should also be given due consideration. Now, the lymphovascular space invasion, which is a very strong adverse prognostic parameter for endometrial malignancies, independent of histology grade or depth of myometrial invasion. And it correlates very well with nodal involvement. And nowadays, with current advancements in the field of IHC, we have the MARG. Previously, it was difficult to comment for the pathologist on LVSI because of the stromal retraction, the artifacts that we could see. But now, with the advent of the factor 7, CD31, and we can identify these endothelial line spaces properly, and we can, comment on lymphovascular. So state, it has been seen that yes, associated with lower adverse factors. So it usually, if these factors are present, that they predominantly affect the outcome and not the cervical involvement. So the question is whether it should really be a part of staging. Now the lymph node staging has changed from the complete systematic lymphadenectomy to sentinel node dissection, and that is actually the standard of care in endometrial cancer. And then therefore in the staging it should be mentioned at least as footnote, and the extent of dissection should also be mentioned. And of course the molecular staging, which is very important, and everybody is working on it, and a lot of data is being accumulated on the molecular staging by using these TCGA categories, or so these are the 4 subvariants like poly, MMR, P53, and the none of the above, or TCGA, copy number low, or promise NSMP classifiers. So these should be a part of staging. So based on this analysis, a proposal was sent for FIGO. It was published in the FIGO cancer report for staging of endometrial cancer by Dr. Amita Maheshwari and Dr. Sudeep Gupta et al. And there were certain changes which were recommended to stage endometrial cancer. And now I'll straight away come to the staging of endometrial cancer, the revised staging, and we'll briefly understand what they have changed. So endometrial, they have given us 2 tables. One is where molecular classification is not available, where endometrial cancer, the surgical pathological staging, the pathological assessment is given due importance. And in all, they recommend that in all the stages, the grade of the lesion, the histological type, and LVSI should be recorded. And the second table, it is given due consideration when molecular classification is available. And it is recommended that molecular classification testing should be encouraged. The complete panel should be done for all endometrial cancer patients for prognostic group stratification and as factors that might influence adjuvant treatment decisions. So the stage 1A. Let's first see what is stage 1. It is confined to the uterine corpus and is associated with good prognosis. The stage 1 is subdivided into 1A and 1B. Stage 1A is where the disease is limited to endometrium or various other non-aggressive histotypes, that is low-grade endometrioid cancer, with invasion of less than half of myometrium with no or focal LVSI, or the tumors of good prognosis, and they divide them into stage 1A1, 1A2, and 1A3. So 1A1, when the disease is limited to endometrial polyp or confined to the endometrium. 1A2 is non-aggressive histologies which are involving less than half of the myometrium with no or focal LVSI. 1A3 is again low-grade endometrioid, which is limited to uterus and ovary. Here they have given a criteria because extensive involvement of the adnexa is given as stage. Further, we will see it is staged as 3A2. But here in 1A3, they have very nicely explained that if less than 50% myometrial invasion, if there is absence of substantial LVSI or absence of additional metastasis, or the ovarian tumor is only unilateral without capsular invasion or rupture, then it should be staged as 1A3. Now, 1B is again non-aggressive histotypes, but invasion of half or more of the myometrium with no or focal LVSI. So basically, they have given due importance to LVSI, histology, and myometrial invasion as it was before. Now, stage 2. It is invasion of cervical stroma without extrauterine extension or substantial LVSI or aggressive histological types with myometrial invasion. Now, this is previously it was only stage 2. Now it is 2A, 2B, 2C. 2A is invasion of the cervical stroma, 2B is substantial LVSI, and 2 is aggressive histotypes with myometrial invasion. Aggressive histotypes we all know, so I'm not repeating it. Stage 3, local and a regional spread of the tumor. Stage 3 is further subdivided into 3A, 3B, and 3C as before. 3A is invasion of uterine serosa adnexa or both by direct extension or metastasis. 3B is metastasis or direct spread to the vagina and parametria or to the pelvic peritoneum. 3C is metastasis to pelvic or paraaortic nodes or both. Now they have further subdivided these all stage 3A into 3A1 and 3A2. 3A1 is spread to ovary or fallopian tube, except when this criteria is not met. Stage 3A2, where there is involvement of uterine subserosa or spread through the uterine serosa. 3B is again 3B1 and 3B2. 3B1 is direct spread to vagina and or parametria or to pelvic peritoneum. The important thing is here is 3B1 is okay, spread to vagina or parametria, but 3B2 is metastasis to pelvic peritoneum. They have specifically identified 3B2 as metastasis to pelvic peritoneum. The abdominal peritoneum, they would further substage as 4B. 3C is metastasis to pelvic or paraaortic nodes, and based on the micro versus macro metastasis, they have subdivided into 3C1, 0.1 and 0.2. Same way 3C2, they have done pelvic versus paraaortic as before, only addition is micro versus macro metastasis. Now stage 4, unlike other stagings, they have subdivided into 4A, 4B and 4C. 4A is invasion to bladder, intestinal mucosa or both. 4B, peritoneal mets, intraperitoneal carcinomatosis beyond the pelvis. 4C is distant, including inguinal nodes, lung, liver, or bone. So this is where molecular classification is not known. If they say that the molecular classification is known, it is given, it is to be considered because it allows a better prognostication in a staging or prognostic system. So the performance of a complete molecular classification is encouraged to all endometrial cancer cases for prognostic risk group stratification. Molecular subtype assignment can be done on a biopsy, in which case it need not be repeated on the hysterectomy specimen. So, and good and intermediate and poor prognosis cases, as we know, poly is good, intermediate is MMRD and or NSMP, and poor is P53. So here, this is the thing is, if molecular classification is known, then FIGO stage 1 and 2 are based on surgical, anatomical, and histological findings initially. But once molecular word comes, then should it be modified by the inclusion, and a subscript M should be added to denote this addition, like as they are showing below. FIGO stage 3 is based same way on, again, on the surgical or anatomical finding, and stage category is not modified by molecular profiling when molecular classifications reveals P53. So you don't need to change it. Similarly, in stage 4 also, it is based the same way on the surgical anatomical findings, and after addition of the molecular profiling, it need not change because it's already high stage, right? So this is how it is to be noted. Stage 3, M, P53 abnormal. So this is how we have to annotate the stage. So for example, this is a pole mutated endometrial carcinoma, which is confined to uterine corpus or with cervical extension, regardless of degree of LVSI or histological type, 1AM pole mutated. This is how we have to write it now. So regarding the same thing, which you all know that there's no alteration in that concept, then MMRD or NSMP status does not modify FIGO stage, since these two categories are each associated with intermediate prognosis, and they both serve as reference to poly-M or P53. Multiple classifiers, we all know that poly is given predominance over others, and similarly, MMRD will be given predominance over P53 abnormal. So I would like to conclude by saying that yes, appraisal of new data, it supports the changes. Yes, new staging appears more complex, but yes, in the era of precision medicine, the new staging looks more granular, more precise, And it should be able to stratify patients more accurately to individualize the adjuvant therapy. And yes, it has added to more and more substages, but we should be able to prognosticate patients now, maybe in a better way. And yes, we all need to go back and review our own data and see if it is fitting well. Thank you so much for your patient hearing.
Thank you so much, Dr. Seema. It had been a wonderful presentation. And I think you have put up, all the things required, which we all in day-to-day practice also, we feel that what we should really be considering so far as the adjuvant treatment is concerned. Should we consider LVSI, or actually whether it is focal or simple actually when it is extensive? Other than this, molecular markers these days is really, it has become, looks like going to become a standard of care. And we have another speaker in this. I think any of the questions we have, Dr. Neha, put the chat box. So we can definitely go ahead right now.
Yes, we can go ahead with
Okay.
Dr. Satinder, yes.
Okay. So invite Dr. Satinder now for her talk, and she is going to see whether it is really required. Staging is required.
New staging of endometrial cancer. Do we all agree? Let's hear from Dr. Satinder Kaur, who is the Director, Senior Consultant, Gynae-Onco at Dharamshila Narayan Super Speciality Hospital. We welcome you, ma'am. Would like to hear your opinion on the same.
Yeah, hi, I am not able to share my screen.
You should be able to do it
Ma'am,
now.
you will be able to know.
Pancham was sharing first.
Okay. No.
Nidhi, can you help us?
So,
Ma'am,
Dr. Pancham?
I have given her the authority to share her screen. She has to try. Ma'am, please try go to the share option, no? In the
yeah, I'm trying, but
Share option is at the bottom, Satinder.
can I say that I know, ma'am.
That you are
I'm
able to see that? Okay.
Yes, I'm able to see that. Okay. Yeah. Neha, can I send you my slides if you can share it from your end?
Yeah, okay.
Okay.
But in the meantime, Nidhi, can you just...
I am trying in the
Yes.
meantime. And
Yes. Yeah.
so I have WhatsApped you my PPT if you can just...
In the meanwhile, there's a question in the chat box if Dr. Seema can answer. After this staging, does this term synchronous primary of uterus and ovary still viable term, or this term is discarded?
Well, I would say, Sarika, that it's too early to say that, whether it will be discarded or not. This staging, what I presented, is not yet published. So I think this discussion is a little too early. But apparently, the way they have written that early invasion and late invasion 183 and this thing, then it should, I think it will not be much in practice, because we'll have to stage them accordingly. So I just don't know that whether it will remain or not. Can't say actually.
Okay. If I may comment, and I think we have
Dr. Satinder, just give me 2 minutes.
Can you see my slide?
Yeah, we can see.
Yeah, we can see your slides now.
Yeah.
But I think this question was from Dr. Sarika. Dr. Sarika, these are the two different conditions. What we are talking right now about, what Dr. Seema has shown is basically this staging proposed for endometrial cancer only. So far as the synchronous malignancy is concerned, I think this doesn't include into any kind of the staging, and it's a different actually entity. So we now invite Dr. Satinder to please present her talk.
Yeah, thank you so much, ma'am. So Seema has given a very nice introduction about the new slides, and Neha has given me a very difficult task to do, but I'm trying my best. I think, yes, definitely the FIGO staging has been changing. It's the first staging of endometrial cancer came in 1950, and then every 10 years, the staging changed, but it was a clinical staging. In 1988, the staging came to change to surgical-pathological, and then 20 years down, it was again modified in 2009, and still we are following that 2009 staging. And we all are very well aware of the 2009 surgical-pathological staging, which we have been following, and it was a very simple staging, which we could actually easily remember and easily follow up all these patients with this staging, classify them, a very homogeneous group, so that all over the world, the same classification can be used and we can group the patients into a similar kind of category. But over the time, definitely there have been a lot of changes in the molecular classification based on TCGA. There have been a lot of changes in pathology, as Dr. Seema has already discussed about LVSI, focal, substantial, changes in risk stratification to tire grading systems, then newer moleculars like L1-CAM, HER2, CTNN, B1, ERPR. And but and this definitely needed a change. So yes, I agree that the staging needed to incorporate the molecular classification and the new insights in pathology was needed. But as I said, the FIGO needs to give, it has a tradition and it needs to give a staging which is easier to be compared all over the world. We cannot give a personalized staging in the era of precision medicine. A personalized treatment is definitely needed for each patient, but this staging looks more like a personalized staging for each patient, and it seems to be quite confusing when we compare it to with the 2009 staging. So ideally, the FIGO staging should be valid, reliable, practical, and adaptable to the significant scientific changes. So yes, we are adapting to the significant scientific changes, but it has to be practical and reliable also. Let's see whether this FIGO staging fulfills this criteria or not. This is the proposed staging, which Dr. Seema has discussed. This is a disclaimer. This is just a proposed staging. This staging has not been published anywhere. So as of now, we are not supposed to remember till it gets published. So we are just discussing it beforehand, which is maybe may not be actually the right thing also, but yes, it's just for discussion point of view. As Neha said, it's not a debate, it's just for discussion point of view. So this is the pathological basis of this. So, sorry, if we remember in 2009, the FIGO staging was changed to simplify the 1988 staging. So this combining of stage 1A, 1B was formed on the basis of FIGO annual report of 42,000 patients, which was the first report after the patients had been started surgically staged. So in the volume 23, 24, 25, they actually saw that patients of stage 1A grade 1 and 2 and stage 1B grade 1 and 2, that is the tumor confined to endometrium and less than 50% of the myometrium, had same survival almost in the range of 93-91%. And that is why they thought it would be good to combine stage 1A and 1B, though the 3 grades still applied to this classification. So, but in this classification, this has been changed. So was there a need to change this classification? I am really not sure, because are we just going the retro way? Was it needed to classify 1A1 and 1A2 and 1A3? 1A3, if we see, as we have already discussed, synchronous endometrium ovary, it's already very rare. Was it needed to actually put this into the classification? And was it needed to reclassify the patients on basis of myometrial invasion again? And even in the study by Dr. Amita, it has been shown that the myometrial invasion, the way it was done, it was correct. You did not need to modify the staging. Definitely, the grades need to be applied, but then again, reclassifying them is a real question. Then the size of the tumor has not been taken into consideration, which actually is an important factor. So we all know there's a retrospective study of 381 patients also, and there are the Mayo criteria also, which say that lymph node dissection should be avoided in patients with less than 2 centimeter tumor size and less than 50% myometrial invasion. And in this retrospective study of 381 patients also, it was seen that patient with tumor size less than 2 centimeter had no lymph node mets. And more than 2 centimeter, the lymph node met was around 7%. But tumor size has not been taken into consideration in this new classification again. Now coming to LVSI. LVSI is definitely a very important factor, and actually the risk characterization had already started changing because of LVSI. The guidelines of changing the management had started, and so it was needed to incorporate it in the staging. But the problem is, if we go by the CAP protocol, the latest CAP protocol, which has been published in December 22, and the pathologists are following, the extensive LVSI is defined as greater than or equal to 3 vessel involvement. But the WHO defines LVSI as 5 vessel, substantial LVSI is 5 vessel involved or more. And the latest classification is following the WHO definition of substantial LVSI. So my question is, when the pathologists themselves are not very sure what is extensive LVSI as of now, so there is no concordance amongst pathologists on basis of this, then should we incorporate it so soon? Another important thing about LVI is that CAP protocol says that you have to also look at the location of LVSI, whether it is in deep myometrial location, it is in cervix, it is in parametrium. So if there is LVSI in parametrium, should that be included as stage 3B? Should we take it as parametrial involvement, or should we take it as stage 2 as per the new staging? So because this is a very important prognostic factor, so we actually need to see what is to be done, which is as of now is not well defined. Similarly, an unequivocal LVSI also has shown prognostic significance, but even that has not been included in this staging. So yes, we need to incorporate LVSI, but before that, we need to accurately define what a focal versus substantial LVSI is, what is the importance of location of LVSI, and what an unequivocal LVSI has. How do we need to deal with unequivocal LVSI? The second important thing which they have done is they have divided the staging based on type of histologies. And in this, the two-tier grading system has been used, and grade 1 and 2 endometrioid have been put into low grade, while high-grade endometrioid, serous, clear cell, undifferentiated, mixed, GI mucinous, and carcinosarcoma have been grouped together, which is a very big group. There is suboptimal inter-observer reproducibility among pathologists regarding the grade also. There is a big study of, 2013 in which 56 tumors of high-grade endometrioid were examined by 3 experienced gynae pathologists. And it was seen the concordance rate was only 62%. So though IHC has been an important adjunct to it, but even IHC has not been sufficiently discriminatory. So maybe, as Neha said, AI may help in finding out which actually is a high-grade tumor and which is a low-grade tumor, that the time will tell. But as of now, the concordance rate is low among the pathologists for this factor also. Now, second important thing in this is, see, we all know that pole mutation is positive in high-grade endometrioids, grade 3 endometrioid tumors. So, and one with pole mutation have a very good prognosis. But on the other hand, if we go by pathological staging and it is a grade 3 endometrioid, we are upstaging it at every stage. But the same patient, if we have the facility for pole mutation, then we will put it into stage 1, even if it is stage 2 grade 3 endometrioid tumor. If it has gone into cervix, there is more than 50% myometrial invasion, grade 3 endometrioid with a pole mutation will be put into stage 1. But a grade 3 endometrioid with cervical involvement, if you do not have the facility for pole mutation, you will be upstaging it. So same set of patients, you are treating in a different way. So we need a further clarity for these patients. Another thing is, in an analysis of 4180 patients of SEER data, it was seen that poor outcomes are seen in serous and clear cell carcinoma when we compare them to grade 3 endometrioid. So the issue whether a grade 3 endometrioid is as clinically aggressive as serous or clear cell has not been conclusively settled. So isn't it too early to group these two groups together, or we should wait for more data to come in? Now, coming to the molecular classification. Now, the biggest caveat is that most of the people do not have the facility for molecular classification. Most of us, even in India, even in Delhi, we are doing MMR and P53 by IHC, but we are not able to do pole mutation. So what is happening as of now is we are treating as per the facilities we have. We are just, if the patient is P53 positive, then definitely they are getting more, we are going towards higher forms of treatment. But we are not able to do pole, and we are not able to, as recommended in this risk stratification, we are not able to avoid treatment in patients with pole mutation because we are not having the facilities for pole. They're not so easily available. Only few patients who can afford it are able to get it, but it's not so easily available. It's not so cheap that every patient can get it done. But anyways, since the classification itself says we'll be doing it for where the facility is available. So let's talk about the situation when we have all the facilities, how to interpret pole mutation is again a big question. So this Castillo et al. Did all somatic pole mutation in the TCGA group. There were 82 with somatic pole mutation. Out of these, 72%, 59 tumors were located in the exonucleus domain. The pole mutation out of exonucleus domain are considered non-pathogenic. Even in exonucleus domain, only 21 variants were seen, which were seen in the exonucleus domain, which were pathogenic. Of these 21 strains, there were only a list of 11 mutations, which were recommended by them as gold standard for clinical testing. Out of these 11 mutations, only 5 mutations were reliably taken as pole positive or true positive, because they had elevated TMB levels. So further data is still needed to define what a pathogenic pole mutation is. So there is another study from Zanoni et al., which says currently there is no surrogate marker for pole mutation, and targeting sequence for common mutations or whole genome or panel testing must be used. So for changing the it is non-pathogenic pole mutation. So we need further studies based on this to what to do about these things, how to interpret pole. Next is, if suppose you have all the best of molecular pathologists and you are able to correctly identify pole mutation also. You see those 5 hotspot mutations, you have a very good molecular pathologist and he has identified that this is a pathogenic pole mutation. Now, what is to be done of this pathogenic pole mutation? So this study of meta-analysis of 359 women with pole mutated endometrial cancer was identified. This is the largest known cohort in which 294 patients had pathogenic mutation. So we all know this all is a retrospective data. In this study, 60% of the patients had received some form of adjuvant therapy. There were only 28 patients with intermediate risk and 14 patients with high risk who did not receive adjuvant therapy. So we really don't know whether the excellent outcome in this group is because of the increased sensitivity to treatment, or these women did not need any form of adjuvant treatment. So extreme caution has to be taken to ensure that we are not jeopardizing these excellent outcomes for women with pole mutation by recommending them that they do not take any adjuvant treatment. So we still need to understand the prognostic and predictive value of molecular classification before we jump onto anything. So transitioning to action on clinical management on the basis of these subtypes requires prospective trials. Now coming to P53. P53 again has its own problems and pitfalls. Though there has been a 4-tier system recommended by pathologists, but as we see, there are plenty of pitfalls in reporting of P53 IHC itself also. Amongst the pathologists, there's a lot of confusion. But only a validated, optimized laboratory, which has a good positive and a good negative control with a good IHC staining is required, and a correct pathological interpretation is required. So definitely we need more pathological criteria and a better definition of P53 for a better inter-laboratory concordance before we change the staging. Next important thing is, we know that NSMP has not been taken into consideration in this group. They have said that it belongs to intermediate group and we do not need to upstage the patient based on NSMP. But in the NSMP group, there is we all know there is a mutation, this L1 CAM mutation, which if positive, it has a prognosis which is even poorer than P53. So they are much more aggressive than even P53 mutation. So this group has not been taken into consideration in this classification. Then we also know in the pathological classification that ER/PR positive tumors, they do very well. So these prognostic factors have not been taken into consideration in the new staging, which I think should be involved. So to conclude, before better definition of pathological criteria is must for making these factors reproducible and hence change the stage accordingly. Molecular staging is also still in its infancy, and with so many unsolved questions, isn't it too early to change the classification? So basic aim of classification of grouping similar outcome patients may be defined if we use this classification as of now, and we need further prospective data before we make these changes. But finally, to conclude, I will say, I thank God I am a surgeon and this is a surgico-pathological staging. At least it is not changing our surgery. Whatever happens is next. So I will wish my radiation and medical oncology colleagues a very all the best to them, because they have to actually change the management based on this staging. Thank you so much.
Thank you so much, Dr. Rupinder. So I think Rupinder has raised rather a debate. Dr. Bafna and anyone else, please comment.
That was really lovely, Dr. Satinder. I love that we are surgeons, so we are not.
Yeah. So, but I disagree with this. Let's see what Dr. Bafna agrees. Whether Dr. Bafna, do you agree with this comment?
Yeah,
Whatever Dr. Satinder really closed
excellent,
down.
excellent presentation by Dr. Satinder.
Thank you.
I think I would fully agree with her. It's too early to change the staging for endometrial cancer. I think endometrial cancer is generally a good cancer with 5-year overall survival of around 90%, according to the SEER data. So I think we don't have to make it very complicated by using so many different prognostic factors, which is going to be beyond the grasp of human mind, and is going to make the life more and more complicated. And all this kind of different prognostic factors, different imaging modalities, different pathological factors is going to come with its own problems. Okay, all these solutions will give you own different kind of problems. I think we don't need so complicated staging at present till we have enough data, till we have enough clarification about the molecular aspects. Right now, the molecular classification is based on PROTECT 3 trial, which is actually not powered to define the molecular characteristics features. I think we have to wait for some more trials. We have to wait for PROTECT 4A trial, which is only for early stage endometrial cancer. We also need some more trials like Rainbow trial. Only then I think we will have more clarity about whether to go ahead and make it more complicated. I think till then, I think I'm happy with the old staging.
I think this is a great debate so far as to consider whether it is the early stage of the disease. And if suppose we are talking about type 1 cancers, I think I do not know where do these molecular markers really work. But of course, with that of the addition of all these molecular markers, where of course the prognosis is a question. So this is a debatable, and I think let's wait for the further. But Satinder, I just would like to make one comment on it. We are very much concerned where the patient should really be getting the adjuvant treatment. If the GYN oncologists are not satisfied, I don't think so. We are going to fulfill, I mean to say, we are going to accept the adjuvant treatment, whether it is chemotherapy or whether it is radiation therapy. So I think let's move on to the next. Dr. Neha.
Yes, yes.
Yeah, Dr. Ahuja. Yeah, Dr. Ahuja. Good. Welcome. Good to see you.
Yeah, thank you. I thought maybe I could just add a couple of things, but I'm not sure whether I'm audible. I'm trying a new Bluetooth phone.
No,
now.
you are audible.
Okay. See, both the talks were excellent. We should first define what we are looking at when we're talking about staging, and what the second is a molecular it should not be more complicated. But when we possible should be given. So we cannot completely ignore molecular classification. The question great tumors also, but we should understand overall the polymutations are less than 10%. Majority are in the good prognosis patient, the lesser grade patient. Some of them are in high grade, and when we talk of high grade, we have not to consider these mutations in higher stages. So a very limited number of patients could cause confusion about this polymutation in a high grade cancer. But what we also understand is that none of these patients, we don't have enough data of untreated patients, all are treated patients. Secondly, we also know that a large proportion, I won't say a large proportion, significant number of polymutations have lymph node metastasis. They also have advanced disease. So they are exactly not benign changes. There may be some other cofactors. Now, similarly, if you take this NSMP, which she has rightly mentioned, this is a very broad category. The broadest category, we don't have any idea. Yeah, we are just putting this category conveniently and putting it aside. and saying that these patients know nothing specific is there. So in this, obviously, we are not anywhere close to having a perfect molecular classification. We really need to do, but whatever we have, like P53 is a useful thing. It is a cheap test, it's convenient test. It helps us. So we should give it adequate importance right now because data is available. Patients with P53 don't do well. MMRD again is useful because it identifies a family Welling syndrome. It identifies a population with recurrent tumors who may benefit with PDL1, but again, that is an expensive treatment, but at least it has a role to play. So as we evolve in the understanding of molecular classification, I think we learn more and more. But as of staging, to compare data and all, we should not make it more complicated. That's all. Thank
Just
you.
a comment
I
on.
I would like to add here one more thing. I think we must take a leave from cervical cancer staging. It has been changed in 2018. I think 2018 cervical cancer staging is very, very complicated. Here you are allowed to use any kind of imaging. You can use PET scan, you can use MRI scan, you can use ultrasonography scan, you can use CT scan. You are allowed to use FNAC, you are allowed to use biopsy. So it's very, very difficult to compare the results between two different centers. So cervical cancer staging, I don't agree with it. I'm not very happy with it. And I think endometrial cancer staging also, we should not make it more complicated. It's going to be difficult to compare between two centers. So I think the thing we should keep staging as simple as possible and should be universally applicable to all the centers across the world.
Yeah, Dr.
Uh,
Satinder, you
I'll
wanted to
just add one
comment?
more
I
thing.
wanted to just add, Dr. Ahuja. So poly mutation is in majority of the cases, though it is seen in less than 10% of endometrial cancer, but it is majorly seen in high grade, not in the low grade cancers. In fact, in low grade setting, it is not advisable to get poly because it's not going to come positive. They advise it
Yeah.
only in grade 3 cancer. Second, as you said, I know the molecular class see, we have already modified the risk stratification based on the molecular staging. So we are going to change the adjuvant treatment as per that when we get the results of rainbow trials and all, and we have some prospective data of changing the risk stratification. So is there actually a need to change the staging also when we are already changing the management? We are planning of trying to change the management. See, ESMO has already recommended risk stratification based on the molecular classification. So that will anyways change the treatment. Once we have more prospective data, we can change our. Should we actually change the staging also? Will it that help? I really don't know. How will that help?
I think it's a very valid point, and the concern is the inclusion of all molecular markers into the stage. I think that's going to be a great task, and I think it's a big question to all of us. So I think we can.
Yes, Dr.
The
Seema.
thing is here,
Seema.
just last comment. The thing is that if we see the
Should we
ESMO
see
risk
you?
stratification system, ma'am, the risk stratification system of ESMO, we operate our patients and then we try to stratify them based on that ESMO criteria of the stratification systems, right? Low risk, intermediate risk, high intermediate risk, and based on both the factors, molecular classification known versus not known. And this staging, 2009 staging, when we try to, kind of correlate with that, it really falls short that way. So this particular, the only thing which I liked about this new staging is that it is in collaboration with that ESMO risk stratification criteria, which ultimately
Study score over high. We will hear from Dr. Maushami Suryavanshi. I would invite Dr. Sachin Khurana, who is an associate professor at Medical Oncology, AIIMS, New Delhi. Over to you, sir.
Thank you very much. Let me try to share my slides. Just give me a second.
Yeah, sure. Nidhi, are you there? Can you help out, please?
Yes, ma'am, I'm here.
Yeah. Okay. So Dr. Sachin.
Sir, are you facing problem in sharing your screen?
Yeah, just give me a second. I think I'll be able to do that in a while.
Yes.
Just give me a second. I'm so sorry for the delay. I might have to log in again. Just give me a second.
Okay.
I think meanwhile, I think I would like to say that vulva cancer staging also was simplified. Earlier, it was a very complicated staging. You just cannot remember. I cannot remember the vulva cancer staging at all. It's so complicated. No, so later on, the vulva classification, FIGO classification was simplified. So I think we don't need very complicated classifications. It's going to be difficult to remember, difficult to apply it in day-to-day practice. The treatment aspects are altogether different. And staging part, I think, should be simple. Should be simple. We should be able to use it in our day-to-day practice. You don't have to think too much. You don't have to use artificial intelligence. Otherwise, everything you need artificial intelligence. You will not be able to do it yourself.
Agreed, Dr.
Artificial intelligence has got its own, complications, which Dr. Neha has not highlighted. We have EVA colposcope, and you have artificial intelligence. It gives you all kinds of reports. It gives you all kinds of wrong reports. It scares the patients. So artificial intelligence, I think, has got its own limitations.
Yes,
So
we can see your slide.
yeah, thank you. I'm really sorry for the delay. There was some technical issue. So the task given to me is regarding HRT testing, whether it's a game changer or not. I'm not sure whether it is. Let's see. So I'll be dividing my talk into this outline. I'll be discussing DNA repair mechanism, then we'll try to discuss HRR and then clinical evidence for HRD and a possible the limitations. So I think are the human DNA is constantly damaged and it is repaired. So but there are certain mechanisms that can properly repair this DNA. Some are perfect, some are imperfect, and it may also altogether fade. So if it's perfect, then we go the normal pathway. If it's imperfect, then maybe and if it will lead to some mutations, and it may promote carcinogenesis. If it fails, and then the cell may die. So then, what are the repair mechanisms which are at the core of this HRD thing? So there are different mechanisms for different types of DNA damage. I think we need to concentrate on this SSBs, the single strand breaks, and the double strand breaks. So PARP enzyme is involved in base excision repair pathway of single strand breaks, and for double stranded breaks, we have HRR and non-homologous end joining, in which certain genes like BRCA1, 2, ATM, CHEK1, etc., they play a role. So for single strand breaks, just concentrate on the base excision repair. The PARP1 enzyme is involved here, and the repair action is actually damage. The damaged bases are excised and replaced with newly synthesized DNA. So what about these double strand breaks? What are the mechanisms we have for that? There is one is HRR, the homologous recombination, which is actually the topic of discussion today. And what action it does it? So actually a sister chromatid is required as a template for new DNA synthesis, and it analyzes the homologous sequences from other parts of genome and collects the lost information at break sites. And point to be noted is it's error-free, and the enzymes involved, the genes involved are BRCA2/1, VALB2, ATM, RAD51, etc., etc. If HRR is not working, so what is the other mechanism? That is non-homologous end joining, which directly rejoins the break ends together and is managed by ATM. And I just told you that this is an error-prone pathway. So the concept of a synthetic lethality, this is at the core of the pathogenesis of ovarian cancer, and it was first identified in a paper in Nature in 2005. So basically, it's like a thing that there are 4 legs of a stool, and if one of the leg is damaged, the stool can still stand. But if the 2 legs are damaged, then so there's a PARP mediated repair and there's HR mediated repair. If one of them is present, the cell may survive. But if both are altered, both are not present, then it results in cell death. And this is synthetic lethality. So what does it mean is that if the DS breaks and the ssDNA break repair mechanism, they are fine. These cells are normal and these cells are viable. If we add PARP inhibitor to normal cells, then still they are viable because the dsDNA break mechanism is active. If HR is deficient, but then the PARP takes over, it is again viable. But if both it's HR deficient as well as we inhibit the PARP enzyme, then it leads to cell death. So there's a lot of sometimes there's a lot of confusion about the terminology. So I'll just take some time to highlight that. So these are the terminologies which are frequently used when we are discussing HRD, HRR, and PARP inhibitors in ovarian cancer. And first one is HRR. This is I just discussed an important error-proof DNA damage repair pathway. So what are HR proficient cells? So these cells are able to repair DNA damage, especially DNA double-strand breaks by homologous recombination repair pathway. And what are HR deficient cells? So this is a condition that homologous recombination repair pathway is impaired in the cells and DNA double-strand breaks are repaired by other error-prone repair pathways, which is any shape I just told you. Then when we label HRD positive and HRD negative, what do we mean? HRD positive means that we have done an HRD assay, and it indicates that the tumors are deficient in the error-proof homologous recombination repair pathway. And HRD negative means that we have done a HRD assay and it indicates that the tumors are proficient in error-proof homologous recombination pathway. So with this terminology, another important point here is there is a cause and effect thing here. So there are certain causes for homologous recombination deficiency. That it might be any gene mutation, copy number variation, or anything else. But more important is the consequence of deficiency in HR. It's not the cause. I mean, ATM gene mutation may be present, or any other BRIP1 something may be present, but it is not definite that these cells will be HR deficient. That means they will not have error-proof pathway to repair the cells. So the consequence is more important. I'll explain it further. So what we do in the test is that it develop a DNA-based assay capable of detecting homologous recombination deficiency regardless of its etiology or mechanism with utility across different tumor sites. So here comes the concept of genotype versus phenotype. So mutations in HR genes, which are very widely used sometimes, like BRIC1, RAD51C, ATM check, etc. But the mutations are not only cause of HRD. It is a differential expression and microRNA regulation which may lead to HRD phenotype. So these gene mutations can be the cause, but they are not the only cause. So patient may test positive for a mutation in HR pathway, but still have an HR proficient phenotype. Patients may not harbor individual mutations, but still exhibit an HR deficient phenotype. So, important is to test this deficiency with a reliable mechanism, which adequately tells us that this cell has an impaired efficiency to repair single strand or double strand breaks, and there is no error-proof pathway to repair that. Now, this is the most common assay which is used, a costly assay. What they use is they try to calculate a genomic instability score. They evaluate the scarring which has happened before, because of different things, and they what are the parameters, what are the things they include in this score is if the tumor BRCA status is positive, then it is positive, or there is loss of heterozygosity or telomeric allelic imbalance or large scale state transitions. And based on these things, they reach to a score which is 42, more than equal to 42 is termed as HRD positive. So that is the most there was an initial assay that was used in different trials. So, but whether it is helpful to us or not, let's see. So, what do clinician need in a biomarker? So, HRD is being considered a very good biomarker, but what do clinician need in that? So, this is an era of precision oncology, and a good biomarker would be which can reliably distinguish between a potential responder and a non-responder when we are using a targeted drug. It would be really helpful also if it can predict the magnitude of benefit. So that would be an ideal biomarker. So it should be present in the patients in whom we are seeing some benefit, and it should not be present in patients who are not responding to the drug in question. And why it's important in ovary cancers, because we know about BRCA mutation since long, but BRCA mutation is present in what around we have around 14 to 50% germline and then 6 to 7% somatic. But this project clearly showed that approximately 50% of the ovarian cancer patients, we all know this, they have some deficiency in their repair pathway, which is homologous recombination deficiency. So how to find out about these rest of the 28% of our patients? So that is the rationale for HRD testing. Again, important to know that HRD, we have to see the genomic instability rather than any gene mutation, because if we add that thing, then it comes to approximately 50%. But if you only count the genes, then that's not adequate. And as I previously told, the patient may have the gene, but we need to see the phenotype, the consequence, which is the scarring that happens. So as we were discussing about a good biomarker, so HRD is possibly a predictive as well as a prognostic biomarker. What is this prognostic thing? That means it has been seen that in the trials which use PARP inhibitors in the placebo arm, when they look at the patients who were HRD positive but BRCA negative, their overall outcome was better than those who were HRD negative as well as BRCA negative. So that also helps to prognosticate the cancer. And overall survival has also been seen to be better in HRD positive patients rather than HRD low score HRD negative patients. So at least this biomarker is helping us for prognosis also. So now going towards the evidence for using this biomarker. So these are the PARP inhibitors which have been used. Olaparib, niraparib, rucaparib. We all know olaparib with bevacizumab has also been used. This is the first line maintenance, and in second line maintenance we have used olaparib, niraparib, and rucaparib. Now these are the basically the treatment arms. This is for first line maintenance. Solo 1 used olaparib in BRCA positive patients. Prima used niraparib in all patients HRD positive negative of BRCA. Paula used olaparib plus bev in every patient, and Athena mono used rucaparib in all patients irrespective of BRCA HRD. So what were the results in brief? Now here comes the utility of this HRD testing. So just concentrate on this. So these are BRCA mutant and HR deficient population. See the difference in PFS. So we can see that in the arm where olaparib was given with bevacizumab, the other arm is only bevacizumab. We can see the patients who were HR deficient or BRCA mutant, they derive the most of the benefit. Similar happened with niraparib. We can see it's 11 months in placebo arm versus 22 months in the niraparib arm. Again, with rucaparib in the Athena mono trial, it was a much better PFS in the HR deficient population with rucaparib rather than in placebo. So let us bifurcate into those. We can say that it's only BRCA which is predicting the benefit. But let's see who were BRCA wild type and HR deficient. Again, there was a difference in Paula also. In HR deficient population, BRCA wild type, where olaparib was used, they derived the most benefit. Again, niraparib was effective as compared to placebo, and then Athena mono. So same results in Athena mono. Now, what if we just do not check, BRCA or this HRD? So let's see the population which is BRCA wild type and HR proficient. So here you can see the difference. There is a difference of 2-3 months here, 2-3 months in Athena mono also. Yes, it was statistically significant also, but is it really clinically meaningful? Can we justify the use of PARP inhibitors in HR proficient patients who are just having a benefit of 2 to 3 months in PFS? The OS data is yet to mature. So here we can use this HRD thing as our biomarker. That yes, there will be some patients who will have benefit, but the modest 2 to 3 months benefit may not justify the use of PARP inhibitor in this population. This is just a summary of these. So now, based on this, in Tata Memorial also, conducted a patient level, patient data and trial level meta-analysis, and they inferred that they look at the patient level data from all the trials, and they concluded that when they included all the trials, the data from all the trials, the benefit of using PARP inhibitor in HRD negative patient was not statistically significant, and they concluded that PARP inhibitor maintenance therapy significantly improved PFS in those with germline or somatic BRCA or HRD, but not in those who are HRD negative tumor. So somebody also did a cost-effective analysis, and they inferred that the high cost of PARP inhibitor maintenance treatment compared with the biomarker-directed PARP inhibitor strategy, they said that maintenance therapy in frontline setting should be reserved for those with germline or somatic HRD mutations until the cost of therapy is significantly reduced. So that was in frontline setting. Now, can we use HRD in second line maintenance or not? So these are all the trials of olaparib, niraparib, and rucaparib in platinum sensitive relapse when they have responded to platinum based therapy, and they were used as maintenance. So there was a solo to use only BRCA positive patients, but no one else used all kind of patients. So what we can see here is again, we can see the benefit was seen in all the patients, HRD positive also, HRD negative also, and BRCA mutant also. So one can argue here is that, and in fact, the approvals were also based on irrespective of BRCA or HRD testing in the relapse setting, that those who respond to platinum-based therapy will respond to PARP inhibitor also. That was the inference. And we were also using a PARP inhibitor in patients irrespective of HRD and BRCA in relapse setting, and using platinum sensitivity, the response to platinum as our biomarker. But again, if we see the magnitude of benefit is not that great in HRD negative patients. And if we go to the overall survival data for niraparib, in fact, in BRCA wild type and HRD negative patients, the placebo group had a better overall survival, and this is the reason that now FDA is kind of suggesting to restrict the use of PARP inhibitors in relapse setting in those who are BRCA positive or possibly HRD positive. We don't have the OS data for HRD positive patients separately. So yes, it was initially that you can use PARP inhibitor irrespective of HRD, but now things are again changing, and the OS data says that you need to have a biomarker possibly in relapse setting also. So again, somebody did a cost-effective analysis in this refractory setting also, sorry, and the relapse setting also, and they found that the treatment of patients with BRCA mutation alone or with HRD positive tumors are preferred strategies compared to treat all strategies. But I think maybe we don't have the right answer now. So this led to our this kind of treatment paradigm which we are using in ovarian cancers in 2021. So we are using HRD as a biomarker to decide on the treatment. So wherever HRD is there, we are trying to use PARP inhibitor. Now this also says that you can use PARP inhibitor in HR proficient patient also, but as I highlighted before, the magnitude of benefit is very less, and our patient level meta-analysis also showed that it is not statistically significant when we compare all the patients in different trials. So are they perfect? Is it really a game changer? I'm not sure, frankly speaking, because these assays are definitely not perfect. We may miss out on some patients who will have benefit, even if they're HRD negative, and there might be some patients who are still HRD positive, but they are not really candidates for PARP inhibitor. The reasons can be, different. These HRD status are based on genomic scars, but they do not reflect the current HR function. Sometimes the cell can, repair itself, and it can again become HR proficient with time. There is intratumor heterogeneity which is not addressed. We all know there are reversion mutations of BRCA1, 2, and etc. And we are also unable to detect any non-HRR gene-related PARP resistance. So questions, still remain whether we need to use archival tissue or fresh tissue. Is HRD actually dynamic? The scar may, repair itself. What to do for reversion mutations in BRCA? And obviously, the cost of the test is quite huge. What's the future? I think we need to develop some cost-effective assays, more reliable assays, and maybe some functional assays are being developed. Some RAD system foci formation assay, DNA fiber assay, and there is another test, using copy number variation and another HRD assay, which are a bit of cost-effective, and they are initially showed good concordance with the myriad assay. So with that, I would like to end my talk and would hand over to Dr. Suryavanshi for her comments on the downside of HRD. Thank you.
So I think it's a beautiful presentation, and what to think about the future, how to go about it. And for diagnosis, I think we need more labs and more setups, so we can go with all this testing, whether it is for the C endometrium or the molecular testings, and they should be in collaboration with each other, so they say the same song or they sing in the same tune. Otherwise, if somebody is saying something and other is giving the reports differently, it is going to be a good confusion. And second thing, regarding the somatic and genetic germline, there is a difference when you do it from the tumor cells. The somatic HRD is difficult to, I think, conclude. Am I right, sir?
Ma'am,
May I
sorry,
answer?
I think, ma'am, Dr.
I think we
Moshmi
can
would
take the
probably be
discussion.
covering that. Yes, we can take the questions in the end in the interest of time.
Okay.
So Dr. Moshmi.
Yeah, shall I begin?
Yes, ma'am, please.
Okay, good evening, everybody. First of all, thank you, Dr. Neha and Oncology Forum for giving me this opportunity, and a lot and big thank you to Dr. Sachin. I think he's done part of my job also. So that's very nice. And before I begin, I like to say that I'm a lab person. I'm all for molecular testing. So, but nothing is perfect. Nothing in life is perfect, and so are these molecular tests, and they have a lot of limitations also. So I start my part of the debate with a real life case. So this is a real life case. She is a 48-year-old female who had serous ovarian cancer, stage 4. HRD score testing was done, and the score was 42, which apparently is a high score. And these scores are calculated by adding 3 parts, and all the 3 parts, there is loss of heterozygosity, large scale transitions, and telomeric allelic imbalance, were high. And together, when they were added, they gave a high HRD score. And this is just to show you a IGV picture. So I could clearly see a large deletion in the BRCA1 gene. So, and the variant allele frequency of the deletion was around 81.87%. So that clearly indicated that this patient was a germline BRCA1 positive, and that is why the HRD score was high. Okay. But this is what the medical oncologist told me. And, they make it a point to tell you that the patient has spent so much money and the patient has not responded. The patient was treated with olaparib and bevacizumab in the first line, and there was no response. So why did this happen? So just let's try to get to the crux of it. What is this HRD score and what is happening? Why are we using this kind of score? So mutations are have an archaeological record of exposure to the mutational process. So whatever insult the body has suffered through these mutations, that impression or that archaeological impression is present on the tumor, and based on that there are multiple signatures. So till now we have defined around 30 signatures. So there could be a signature for aging, signature for smoking. Similarly, there is signature for HRD kind of mutations. So that is the signature, and these signatures actually are the ratio of C to A, C to G, C to T, T to A, and all those type of substitutions. And ideally, you should do a whole exome sequencing to know the true signature of this thing. But since like your tumor mutation burden, you cannot do a whole exome sequencing, that will obviously raise a lot of cost and will give you unnecessarily information which you might not know what to do about. So we have something short of that. We just try to identify one signature for which we already have a drug. And we know that drug is the first one which came, of course, is from is olaparib, and which is coming from a company which is a big, huge pharma company, that's it, AstraZeneca, and it is also promoting its test. So that's why people like me also have become very popular, because they not only promote the medical oncologist, but they also promote the molecular pathologist. So these signatures, which I've been referring to, these are not only based on these single substitution mutation, these also have certain copy number types of signatures. So, but again, these are to be studied in whole exome sequencing. And signature 3 is the classical signature of homologous recombinant deficiency. So that is what we are trying to see. But there are other signatures like signature of aging or some toxin which could also be present on the tumor. So, but unfortunately, I think Dr. Sachin also mentioned that point, that we are just looking at one part of the tumor, one signature of the tumor. The tumor could be carrying a lot of other signatures, probably some signature of smoking type, of aging type, of some toxin type, or some base excision repair defect type of signature could also be there. And the combined effect of these signatures is the signature which is the signature of the tumor at that particular time. And again, it is not a real-time monitoring. That is another thing. So we just look at the tissue, and most of the time, mind it is an archival tissue which is taken, and we look at a signature on that, look at the HRD score on that tissue. But it is these things are also very dynamic, and they keep on changing with time, and there is no way to assess them each and every time, since these are also very costly tests. So this homologous recombinant deficiency has lot of biomarkers. So one is the germline BRCA1 and BRCA2 mutation testing that we all know of. Then the other way could be looking at the somatic DLEs, BRCA or HRR gene mutations. But unfortunately, none of the people discuss this part, that most of these genes are tumor suppressor genes, and they have 2 alleles, and they will continue to function normally if one of the allele is normal. if having a germline mutation doesn't mean that you have a defective BRCA. It is only when the other normal allele gets silenced or is destroyed, then is the function of BRCA becomes abnormal, and then the tumor starts happening. So, but when we are looking at somatic HRR genes, we are not looking at the other allele. So that is where most of the people go wrong. Just looking at the HRR genes at the tissue level will maybe not give you the true picture. And then there are functional assays, which I will talk of in my subsequent slides. And then there are genomic scars, which we are looking up in the form of your HRD scores. And mutational signatures, of course, we are not seeing. And then there could also be tests to look at the gene expression of the signatures of BRCA-ness, which could be at the RNA level, which again is not a very popular way of doing. So what presently we are doing is the germline or a somatic BRCA or HRR gene testing and the HRD testing. But there could be other ways in which we could look at these signatures. And again, there is another big problem. There is no consistent definition of HRR genes. So different trials have taken different HRR genes. So there are, of course, certain genes like your BRCA1, BRCA2, ATM, CHEK2, and maybe PAL-B2, which are common to most of the trials. But unfortunately, none of them are consistent. So you don't know which of them are actually supposed to be coming in the HRR gene panel. Then I think the definition of HRD has been defined very well by Dr. Sachin. I will not get into that. So we are trying to look at something which is beyond our germline mutations, which has a signature of HRD signature, but may not have the mutation, HRR mutations. So of course, it is a sum total. HRD score is a sum total of three things. First is the loss of heterozygosity, which means the number of regions of representing one parental allele via loss of heterozygosity. So basically, there is a loss of one allele, which has to be more than 15 megabases. So these are bioinformatic terms which are used and may not be for a clinician, but for people like us, we need to see, because if the loss is less and somebody's counted them as a loss of heterozygosity, so then it has to be corrected. Then there is loss at the telomeric region, which are present at the base of the chromosomes, that are also accounted for. Then again, there are large chromosomal losses which could be which have to be more than 100 MV, and which do not include whole chromosome. If your whole chromosome is lost, it will not be calculated in the HRD score. But if only more than 10, but less than whole chromosome, it is calculated. So it is just adding these points. And there is FDA approval only for 2 tests for using these. One is the Midriad genetics, which cost around 2.5 lakhs and which takes into account all these parameters. And the next one is Foundation Medicine, which only uses the loss of heterozygosity. And if you look at the Midriad My Choice test, which is the FDA approved test, ideally, which should be the one which has been used in most of the trials. But this thing is that they initially had a cutoff of 42, which they had lowered to 33, just to bring in more patients. So that is another thing. And how they calculated this score was they calculated these 3 parameters singly, that is the loss of heterozygosity, these large scale transitions, etc. And they tried to divide these patients, which are around 900 patients of ovarian cancer, into the one which had a better survival and a less survival. And they found that there was some cutoff which was close to 40, which could be used when they accumulated all these scores. And when they tried to look at the patients who had BRCA mutations, again, the score of the patients who were BRCA mutant was coming something more than 40 or 42. So that's why this score of 42 was initially considered as the cutoff. But now they have reduced it to 33. And again, this test, they don't accept samples from brain metastasis, bone metastasis, or endometrial tissue. And similarly, for Foundation 1 test, The cutoff initially was 16, which was reduced to 14 to include more patients. So this, I think Dr. Sachin has already shown. But again, cost is a big concern. This test has been offered free via coupons because the company is giving coupons to these medical oncologists and other, so that they can get these patients tested, and hence they can have more patients can have these drugs. But if you want to get them on your own, it may be costing you around 70 to 80,000. But mind it, these are not the FDA approved tests, but these are the other companies which are offering the test, and you are trying to match it to the FDA approved test based on which the approval for this drugs was given. But as Dr. Sachin again mentioned, there are certain tests which could be a good substitute and which are much cheaper. And these are because based on immunofluorescence, and these are RAD51 functional assay test. And if you just look at the sensitivity, specificity, and accuracy compared to the HRD score, though the sensitivity may be slightly less, but the specificity and accuracy are actually performing much better than your HRD score for this assay, which might be very cheap compared to the HRD scored assay. And then, of course, there is a term called reversion mutation, and there were questions also in the chat box. Then what are reversion mutation? So these are mutation when the patient is on cisplatin therapy or on PARP inhibitor therapy, the body tries to repair and these mutations get reversed. So this is also a mechanism of resistance to platinum or PARP inhibitor therapies. So these patients who were HRD score high and BRCA mutated, the BRCA mutations reverse. So when you look at the liquid biopsy sample of these patients, the mutations have gone, they have reversed, and the patient stops responding to the therapy. So this is also a very common phenomena which is not taken into account when you are testing for HRD score, and you might end up paying so much and the costly treatment, but the patient doesn't respond. So the big limitations of this test is, of course, you don't know when to get it at diagnosis or at recurrence, and it doesn't take into account the other signatures which might be present on the tumor. It is just looking at the HRD signature. So that is one big point. So the challenges with it is, the main challenge is that currently these tests fail to identify the patients who are not going to respond to the PARP inhibitor therapy. And if you have seen Dr. Sachin's slide, there were many cases of wild or HRD negative patients who had responded to these therapy. So where do we stand for now? We actually don't know, and some of our decisions or many of our decisions are driven because there is a lot of information regarding this test given by the pharma companies. And the future, I feel, would be just not HRD score, but a responder HRD gram, which will include the immune response, the clinical features, the other genomic features, and the functional assays together. And they will tell us the probability, and still it will not be a perfect test. That I'm minded, I must tell you. So it will give us a probability, which will be the maximum probability of the patients who will respond to this kind of treatment. And with that, I would like to thank you. And this is my last slide. And I don't know how many of you know, this is a doodling which is done by Dr. Neha Kumar. And she is a beautiful doodler, not only a very good surgeon, and her such sketches are available online, and I don't know, she's putting them for sale also. So with that, thank you very much.
Thank you so much, ma'am.
Dr. Maushmi. It was a wonderful talk, and I think the talk ended with a wonderful, I think, I must say, an art by Dr. Neha. I think you have raised a very important question, though there is no time, but I would like to comment on that. What we are thinking about the HRD positive is everything. And we are in practice also facing problems when HRD positive going on the olaparib, and of course the patient not responding. So I think these cases are likely to actually pile up with a little more, and we are going to be a little more focused in our testing. So let's move on to further, and we will have the discussion at the end of the session now. Thank you.
Thank you.
So may I now invite Dr. Abhishek Gulia, Associate Director, Radiation Oncology, JP Hospital, Noida, for his talk on the fact that radiation, adjuvant radiation, is mandatory in patients who have intermediate risk factors post.
Dr. Neha, sorry to interrupt you.
Yes.
May I ask a question to Dr. Moshami?
Oh, yes, sir. Sir, please.
Yeah.
Sorry, we were in the
I'm
interest
sorry.
of time.
Yeah.
We wanted to take questions later. Please go ahead.
Yeah, so a wonderful talk by Dr. Moshami. I would like to ask Dr. Moshami whether the Indian laboratories like Strand Laboratory, MedGenome Laboratory we have, and we have 4-base laboratory, they also offer HRD testing for 70,000 to 80,000 rupees. How reliable are these laboratories? Because they are not FDA approved.
Yeah, they are not FDA approved, sir, but I feel FDA approval is also overhyped. You know, there is a set of criteria which means lot of financial burden to the lab, whichever is going to take, and you have to fill those criteria and you can get FDA approval. There are few Indian tests also which have got FDA approval. But if your test is validated against whatever is the gold standard, because here the gold standard is either the foundation or Myriad genetics, and there are set of controls which are available, international controls, and which are very costly controls which are available. If you have validated them, then I think at least for the higher values you are safe. Okay, but the lower and the borderline values, there is no perfect test there, but higher values, yes, you are safe.
Okay, so my question now would be Dr. Sachin also. Is it there?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Since the HRD test also is not a perfect test, and anyway, the FDA has approved rucaparib and niraparib as a maintenance therapy, irrespective of whether they are HRD deficient or HRD proficient. Can we use indirect surrogate marker that is platinum sensitive, highly platinum sensitive ovarian cancer patients instead of doing HRD testing? And since they are approved for both HRD proficient and HRD deficient tumors, why not directly put them on maintenance therapy instead of relying on HRD testing, which is not very reliable?
Sir, rightly pointed out. That's why I said included some slides. So yes, niraparib is approved. Rucaparib is yet to be approved, but it will get approved. Point here is the magnitude of benefit in HRD deficient population is not really great. Whatever HRD test we have, that is the only test we have available. I mean, whatever beats accuracy or row, but the magnitude of benefit is like 2.5 to 3 months. And a meta-analysis showed that, in fact, in HRD negative patients, when they included all the patients from different trials, it was not statistically significant. Another point is, so we have been using platinum sensitivity as a surrogate biomarker, but that was possible in relapsed patients. Now, just imagine a patient who has been upfront debulked and now is taking, and it's R0 section, there is no tumor. We give 6 cycles of chemotherapy. How we define platinum sensitivity is when the disease comes back, and it comes back within 6 months of the last chemotherapy. So by that time, we have to start this therapy. And in fact, even in patients in whom we are giving NSAT, even if they respond nicely to platinum, we don't know whether disease will come back in next 6 months or not. So at that point of time, when there is end of treatment for the primary patient, we need to take these biomarkers only into account, either BRCA positivity or these HRD assays, which at least tell us that this is the magnitude of benefit you will get. In HRD positive, it is a good benefit. In HRD negative, there is a benefit, but it's a small benefit. Whether you really want to expose the patient to PARP inhibitor HRD negative or not, that is for the clinician to decide.
We need to say that 2 to 3 months PFS is not enough.
Yes, sir. As a clinician, it's not clinically meaningful. It may be statistically significant, but not clinically meaningful. Yes, sir.
Okay, fine. Okay, thank you.
Thanks, sir.
Yes, Dr. Abhishek, please go ahead. Thank you.
Thank you, organizers, for the opportunity, and a very good evening to all. This one is the last session for the day, I guess. And my topic is adjuvant radiation is mandatory in intermediate risk cancer cervix post radical hysterectomy. And I'll be speaking for the motion. Yeah. So whenever we are discussing this intermediate risk cancer cervix, and I'm the first presenter, so it's my responsibility to discuss the risk factors also. The risk factors are classically described as the classic criteria, and then they were further refined by the GOG 049 trial and used in GOG 092 trial, famously known as SEDLIS criteria, which are being used currently in the NCCN as well, in which early stages of carcinoma cervix, most with these kind of combinations of LVSI, lymphovascular space invasion, stromal invasion, and tumor size, any combination of these two factors warrant the use of adjuvant therapy. So these are the risk factors. However, in the recent trials, more specifically in the Cervantes trial, which is underway for this particular topic, the inclusion criteria includes FIGO 1B1 and 2A stages, FIGO 1B2 as well, and 2A1 stages. And the high risk features, specifically lymph node positivity, margin spread, margin positivity, are excluded. The inclusion criteria specifically includes tumor more than or equal to 4 centimeter, or any tumor which is 2 to 4 centimeter with lymphovascular space invasion, or any tumor which is 2 to 4 centimeter along with newer factor which is incorporated, like tumor-free distance less than 3 millimeters, or any tumor which is 2 to 4 centimeter with deep stromal invasion that is more than 2/3 of the total thickness. Now, there are other factors also which are being investigated and being brought up by the various groups. First is tumor budding in cervical cancer, and then there is tumor-free distance. So these factors are more and more indicating about the pathology of the disease and how much we should incorporate adjuvant treatments in these kind of diseases. Now, why this discussion, particularly in a forum like this? Of late, there have been some reports and some review articles in which it has been questioned whether adjuvant radiation altogether is required after surgery in early stage intermediate risk carcinoma cervix patients. Now, I have left those studies to be put up by my colleague, Dr. Modi, who will be speaking next on this topic. But there have been conflicting reports, and some of these, like the one we are seeing at the moment, is from South Korea, published in 2020. Which again stresses the fact that in this particular patient population, implementation of adjuvant radiation significantly reduced the disease recurrence rate in patients with intermediate risk, stage 1B, 2A cervical cancer treated primarily with surgery. But I'll be speaking and I'll be focusing more on level 1 evidences. Now, this is one of the level 1 evidence. As we all know, this is a Cochrane review based on mainly 2 randomized control trial review, in which was published in 2012, and it again stresses that women who received radiation had a significantly lower risk of disease progression at 5 years. So the review articles of the level 1 evidence advocates the use of radiation. Till date, the only randomized control trial deciding on this topic is the GOG 92 study, published way back in 1999, which was a randomized trial of pelvic radiation therapy versus no further therapy in selected patients with 1B carcinoma of cervix after surgery. And this was a GOG study published in 1999 rather. In this, all patients who were 1B underwent surgery were included. In the post-op setting, to be included, patients had to have 2 risk features amongst the listed, famously known as the SEDLIS criteria. Total number of patients who were fitting into the inclusion criteria were 277. They were randomized equally in both the arms. 137 received post-op radiation and 140 did not go for any kind of adjuvant therapy. And importantly, what this randomized control trial shows is that live table analysis indicated a statistically significant around 47% reduction in the risk of recurrence, p-value significant, amongst the radiation group, with a recurrence-free rate at 2 years of 88% versus 79% in favor of radiation versus no further treatment. So the trial concluded that adjuvant pelvic radiotherapy following radical surgery reduces the number of recurrences in women with stage 1B cervical cancer at the cost of 6% grade 3 and 4 adverse effects versus 2% in no radiation arm. So The concern which was there was with adjuvant radiation was higher degree of grade 3 and 4 side effects. An update on the same population of patients was published by Rotman et al. In 2006. And the discussion, the first paragraph of discussion in their publication is the current topic of discussion in this forum. The results from this retrospective studies have disagreed. That was way back in 2006, they've written, have disagreed as to the value of post-operative radiation in node-negative stage 1B cervix cancer. As discussed in the previous publication, complications were a major concern. Now, what they concluded after analyzing it for a long term, the patient population for a long term, was a significant reduction in the risk of progression or death occurred with radiation compared with observation, p-value significant. The progression-free survival was significantly improved with adjuvant radiation. In the current study, only 8.8% of the patients with adenocarcinoma or adenosquamous carcinoma in the radiation arm recurred versus 44% in the observation arm. This outcome suggests that radiation may be very valuable for such patients. More so, they observed that after controls were applied for prognostic subgroups, radiation patients were 44% less likely to recur as compared to the observation patients, p-value significant. And they concluded that pelvic radiotherapy after radical surgery significantly reduces the risk of recurrence and prolongs progression-free survival in women with stage 1B cervical cancer with intermediate risk factors. And radiation appears to be particularly beneficial for patients with adenocarcinoma or adenosquamous histologies. Now, as far as whenever we are talking about these kind of studies, which were published obviously in 2006 and 1999 and are very concerned about the complications, so we should see that this figure A was what was being done at that time. This was the radiation technology which was being used. This we radiation oncologists call as the 4-field box. And this is in the below figure, this is what we do nowadays with the techniques like IMRT and VMAT. So obviously with the dose sculpting that is allowed, the fear of complications should not be an impediment in using adjuvant radiation in these group of patients. Although it must be stressed here that if we anticipate that in future adjuvant radiation will be required in a particular patient, it is always best to send the patient for a radical radiation rather than taking her up for a surgery, after which radiation would be required. Now, we should also, sitting in Delhi, we should know what the world is doing actually. In 2018, an ESGO survey was conducted regarding the current practices, how people do it world over, which was published in 2018. And it was seen in the survey that as high as 81% of the surveyed esteemed faculty considered the combination of tumor size, LVSI, and stromal invasion as an indication for adjuvant radiotherapy. Moreover, 88% of radiation oncologists believe that other prognostic factors also should be considered rather than only set-list criteria while deciding for an adjuvant treatment. Furthermore, 66% considered chemoradiation, not only radiation, but chemoradiation in these cases of LVSI and suboptimal node dissection, and high grade and size more than 4 centimeter and non-squamous histology and combination of these factors. Now, the world is debating rather than use of adjuvant radiation or not. The world is currently currently doing studies like this one, the GOG 2063 trial, 0263 trial, in which which is a randomized trial, of course, and analyzing whether adjuvant radiation versus chemoradiation should be considered in intermediate risk, early stage cervical cancer treated by initial surgery. As far as when we are talking about level 1 evidence, we have guidelines based on these randomized control trials, which are also considered level 1. And this is one of the famous guidelines I'd like to quote. This is the European Society of Gynaecologic Oncology, European Society of Radiotherapy and Oncology, European Society of Pathology guidelines published in 2018, in which they categorically mentioned that adjuvant radiotherapy should be considered in the presence of combination of risk factors at final pathology, such as tumor size, LVSI, and depth of stromal invasion. Our own beloved NCCN guideline, latest version 2023, for patients who have underwent a primary surgery, we should go and analyze what is the adjuvant treatment, and radiation therapy is mentioned as a category 1 recommendation. For the uninitiated, I'd like to stress that other recommendations which are against which the category is not mentioned are category 2A. And as far as SIDLIS criteria and the patients who have this risk factors are considered. Adjuvant radiation is a category 1 recommendation as far as NCCN is concerned. Not only SIDLIS criteria, but other factors are also to be considered whenever we are considering adjuvant treatment. So the indications of radiation, rather than decreasing, are increasing as far as cervical cancer is concerned, with some of the factors we have already discussed in the previous slides, one of being the tumor margins, tumor-free margins, and then there are tumor budding cells. Now, do we have some Indian document on this? We do have an Indian guideline. We are sitting in India, so we should know what the Indian guidelines say. So ICMR guidelines, consensus document, again, categorically mentions that adjuvant therapy after radical surgery for intermediate risk, any 2 factors being present out of tumor more than 4 centimeter, deep stromal invasion present, and LBSI positivity, we should give adjuvant pelvic radiation. Do the Chinese do it any different? No. Again, Chinese are also in agreement with my point of view. 2022 published paper. Again, it says that indications for postoperative pelvic radiotherapy with intermediate middle risk factors they mention. I think it is intermediate risk factors. And again, SIDLIS criteria is the one. They also advocate the use of pelvic radiotherapy after surgery in this patient population. Britishers, again, the British Gynaecological Cancer Society, they say patients who received adjuvant radiotherapy had a significantly improved recurrence-free survival. So again, they also recommend this. Again, the guidelines by ISRO, ISGO, and European Society of Pathologists, as far as guidelines, as far as adjuvant treatment is concerned, adjuvant radiotherapy should be considered in the presence of combination of risk factors at final pathology, such as whatever we have been discussing, tumor size, LVSI, and depth of stromal invasion. Now, when I talk about level 1 evidence, this is a trial which is actually settled this debate. This is Cervantes trial. The accrual, as far as I know, is complete. And in the population, the inclusion criteria we have already discussed. It is a randomized control trial, and no adjuvant treatment in this patient population versus adjuvant treatment. I think this will rather settle the debate. Till then, adjuvant radiation has to be done. Another paper, which is in agreement with me, they have analyzed whether adjuvant treatment after radical surgery or in cervical cancer with intermediate risk factors, is it a time for update? And while they conclude their paper, a very detailed analysis, I think Dr. Modi will be quoting a lot from this paper. In conclusion, Dr. Rodriguez writes, to date, recommendations for the management of early cervical cancer are that adjuvant radiotherapy should be considered in the presence of combination of risk factors at the final pathology. To conclude, evidence-based guidelines based upon level 1 evidence should be followed while deciding management. Recommending treatment based upon unsettled conclusions from anecdotal case reports, retrospective audits, case series should be best avoided because there are a lot of confounding factors which are not accounted for while preparing these kind of reports. And any change in practice deviating from the current standard should only be considered after results from any level 1 evidence study. Thank you.
Yes, very good talk by Dr. Abhishek Gulia. I think after radical hysterectomy, if you are doing surgery for cervical cancer, and if you're going to need radiotherapy in more than 15 to 20% of the cases, then you don't do radical hysterectomy. So straight away refer the patient for radiotherapy. So let us hear Modi's thoughts. Then we come back to the questions and answers.
Yeah.
Rahul.
Yeah. Good evening, everybody. I thank Dr. Neha, and I'll just okay. Are my slides visible now?
Yes, Dr. Modi. Yes.
Yeah. I thank Dr. Neha and DGOG for this kind invitation. So I'll be presenting the other side of the coin, which is it really necessary to give adjuvant radiation in intermediate risk for CA cervix post-radical hysterectomy. So let me come to the birth of the idea from where the intermediate factors came in. So this was the first study by Delgado et al., which is the famous GOG 49 study, which came in 1989, where they told that large tumor size, LVSI, and deep stromal invasion actually increased the risk of recurrence from 2% to 31%. And this was the hypothesis which Sedlis took. And this is the classical GOG 92 study, which recruited patients from 1988 to 1995, almost 3 decades ago. And on the right top are the Sedlis criteria, which Dr. Abhishek has also mentioned. So these were the 2 trials, the Sedlis and the follow-up with the Rotman paper in 2006. I'll not speak much of the paper because Dr. Abhishek has already elaborated much on it. So definitely in both the papers, there was an advantage to the radiation, but probably what was missing from the headlines of both these papers was that there was no overall survival benefit. Although the HR was 0.70, it was not statistically significant. It was powered to give a significance when you have a 45% or more difference in OS, but the difference limited to 30% of advantage. So that's why it was negative for the OS benefit for radiation. Although the risk-free reduction remained the same even at 3 years, which is the Rotman paper, almost 45% risk reduction advantage for recurrences. But why are we revisiting the Sedlis criteria? I'll present some modern day data where the publication is after 2016 and onwards. Second, I also defend by saying, have we gone beyond the era of Sedlis? And third, I think we all look for, as Bhakna sir also told, that we have to balance between oncological safety versus adverse effects of combined treatment, rather than give only one good treatment, rather than combine the therapies and combine the side effects of both the therapies. So what does the modern data say? So I'll speak about the first, which is a very good paper by Dr. Sibula at his institute in the University of Prague. In the Gynae-Onco unit, traditionally no adjuvant radiation was given. And what he did was he compared his data with data from MSKCC, with the Memorial Sloan Kettering, and the Peter MacCallum Institute in Melbourne, in Australia. So 127 cases were his, 104 cases were from US and Australia, where traditionally they used to give radiation after a radical hysterectomy for intermediate risk factors. Now, if we look at the relapse rate, 6.3% in the surgery-only group, which is less than what it is in the combined treatment group. Look at the number of deaths; it is almost half as compared to the combined treatment group. And we look at the curves; no statistical or significant difference. The curves are almost hugging each other, so no difference between. On the contrary, the results were trending more towards benefit towards surgery, but it was not statistically significant. So surgery was the king in this paper, although it is a retrospective evaluation. Another paper from China, where I think the Chinese guidelines were also presented by Dr. Abhishek. So 8 cases, standardized surgery. It was a type C QM or a type 3 pivot at large radical hysterectomy. We look at the data for recurrence-free survival, and even I think Dr. Abhishek spoke about the concurrent chemoradiotherapy part. If we look at the bottom left, no advantage, recurrence-free survival, 87% with observation, 84% with radiotherapy, 89% with concurrent chemoradiotherapy, no difference. But although I like to suggest that, if you look at the subgroup analysis, there was a group where you have the deep 1/3 invasion with LVSI that showed benefit with RT on the subgroup analysis. Again, a single institution paper from Turkey, where they actually looked at the data of 66 versus 68 cases of no adjuvant therapy versus radiation, where a proper standardized type C radical hysterectomy was done in these cases. We look at the recurrences. In observation arm, 19%. RT arm, recurrences were 22%. Overall, the cohort recurrences were 20%. Look at the number of deaths. No adjuvant therapy, 7 deaths happened in that period of time. In RT, 9 deaths happened. Again, the curves trending more in favor of surgery, although not statistically significant. This is a very interesting study from Netherlands where Van der Velden, because in Netherlands, in the Amsterdam Academic Medical Center, it has always been standardized for a type C2 radical hysterectomy from 900 plus cases. They looked at the data that out of 900, 161 odd patients didn't get any therapy. So they tried to retrospectively evaluate the prognosis of these patients. Now, if we look at the total recurrence rate, it was 15% after such a long follow-up. And this is comparable to what is in the RT setting in today's time. But if we look again at the subgroup analysis between squamous and non-squamous histologies, 12% versus 23%. So probably we have to look at the non-squamous histologies more when it comes to adjuvant radiation. So in the Chinese paper, we found LVSI with deep invasion. Here we are finding with such a long follow-up and a big size data of 900 plus, of which 161 didn't have anything. Non-squamous cell carcinomas weren't doing good with observation also. Again, on the same model, there's a Japanese paper from, they did certain amount of type 3 radical hysterectomies. 82 didn't get any adjuvant therapy. They did a retrospective evaluation of these 82 cases. 6 recurred out of the entire data set, 7% recurrence rate, out of which 4 were salvaged, 2 died of disease of 82 patients, giving a 5-year DFS of 92.6% and a 5-year OS of 96.3%, which is at par when you give RT also. Now, if we look at the table where the 6 cases had recurrence, the 3rd case had adenocarcinoma, had a distant metastasis. And rest all, if we look at the deep stromal invasion, it was more than 2/3, LVSI with 1/3 to 2/3. So probably again indicating that, yeah, non-squamous and probably deep invasions along with LVSI are tending more towards getting adjuvant. Now we look at the National Cancer Database. It's a very recent paper by Dimitrios et al. By 387 versus 378 cases. They never looked at recurrence-free, but they looked at the overall survival. So HR was 0.86 in the favor of RT, not statistically significant. If you look at the 4-year OS, 89% versus 86%. So no overall survival benefit for these patients. And this data was very recent, which is 2010 to 2015. These cases were accumulated. So let's, on the other side, on my second point, that whether SEDLIS is a 3-decade-old concept. And I think Dr. Abhishek rightly predicted that I'll use this paper, but I'll use it for this aspect of it, that, yeah, whether we really require an update. It's a 30-year-old study, and a lot of changes have happened. At present, if we look, we know much more better about the parametria, the kind of recurrences, types of hysterectomies are more standardized, pathological developments have been good, introduction of sentinel lymph nodes and ultrastaging to detect better micrometastasis and metastasis. Although advances in radiation and everything have improved, in the old paper, if we look at the data, more than 20% of cases had more than 6 centimeters of tumor, 6 to 8 centimeters of tumor. In today's stage, it could probably go to 1v3 and go for chemoradiation at the upfront, because we already some data is coming up that bulky CA cervix go more towards CTRT. And this paper had 25% of cases which had more than 6 centimeters of tumors. Although the authors have also criticized on the RCT design because regarding the power of the study and everything. So definitely SEDLIS is an age-old concept. So still today, that's the only the phase 3 trial which we have, and that's why probably SEDLIS has become equivalent to intermediate risk factors. So is adjuvant RT really necessary? Not for all. As a basket, you cannot give RT to all. Neither it has to be not to be used at all. Kind of it has to be given a more specific use. It definitely has a role out of all these modern day data. Deep 1/3 invasion, more than 2/3 invasion, non-squamous cell carcinomas like adeno and adenosquamous, they are showing better benefits with radiation in the present day world. And definitely the quality of surgery is important. If you have a non-type C2 radical hysterectomy, because all the papers which I have presented had a very standardized program of radical hysterectomies in their institutes. So probably surgery became almost equivalent, or maybe in some cases better than giving combined therapy for these. Anything to look forward? Again, I'll say the Cervantes trial, and there are certain factors like the tumor-free distance, which Dr. Sibula found that, yeah, instead of giving a deep stromal invasion, the superficial deep stromal invasion, let's go for tumor-free distance. So he has very intelligently given adenocarcinoma only HPV related in this. So because endocervical adenocarcinomas have also undergone a lot of histopathological changes, and innovations have happened with the new classification where it is classified as HPV related and non-HPV related. So he has taken only HPV related of adenocarcinomas with deep stromal invasion more than 2/3, and tumor-free distance is a Prague concept where they found in their entire evaluation of that when only observation was given, where the tumor-free distance was less than 3.5 mm, the patients didn't do well. So he has taken all those factors into account, and so these will be divided into no adjuvant and the adjuvant arm. But as per their official website, the results will be after 2030. So till then, I think we only have this kind of data which is available. Thank you.
It was an excellent presentation, Rahul, and good to see you presenting this topic. I think we have radiation oncologists with us, and most of the time it's a debate whenever we are actually discussing any of the case in the tumor board. So Dr. Bafna, I'm going to say, can we have your inputs on when you would like to consider radiation or when you would not like to consider radiation?
Yeah, I think you can talk for and you can talk against surgery, you can talk for radiotherapy.
Right.
Okay? It depends on where you're working. Okay?
Yeah.
I have personal experience of more than 2,000 radical hysterectomies.
Yeah.
Okay. But unfortunately, most of our patients are lost to follow-up. So I have not published my data. So I don't say that I have a level 1 evidence. But I think over a period of last 35 years, I have got my own conclusions. And I choose my cases very, very strictly here for radical hysterectomy. I choose only those patients where the tumor size is very small. Ideally, it should be less than 3 centimeters. Okay, and I do MRI scan for all the patients to rule out any lymph node metastasis. So you should not have any lymph node metastasis. You should have a small tumor, ideally less than 3 centimeters, and you should not have a deep stromal invasion. And more than stromal invasion, I think you must look at the endocervical extension. Tumor should not be extending to the internal os, isthmus. That is a very critical point, which many papers don't analyze. Okay, and I think if you stick to this criteria, I think we don't need radiotherapy in more than 15% of the patients. If you are not going to choose your patient for surgery, and ultimately you are going to give radiotherapy for 40%, 50% of patients, then rather you don't do surgery at all. You straight away refer the patients for radiotherapy. Now, I would like to, having said that, I would like to ask one question to Abhishek. Okay. Suppose I am a surgeon, I would like to speak in favor of surgery. And I have done a good surgery. I have a patient with a tumor, say 4 centimeter. There's a deep stromal invasion. Patient has got LVSI, got all the risk factors. And the patient needs radiotherapy for this patient because of all the risk factors. But I've done excellent surgery. I'm very confident that lymph nodes are negative. Parameter is very good margins. I've got vagina, I got good margins. I would not like to refer for radiotherapy. I would like to wait and watch. Okay, and reserve radiotherapy when patient recurs. So what is there? I think there are some data available. When you reserve radiotherapy for recurrent tumors, you can reduce the incidence of adjuvant radiotherapy. At the same time, you will not compromise with the overall survival. So do you have any data on this? Reserve radiotherapy for recurrence. So they have a good follow-up initially, every 2 months for first year. Then reserve radiotherapy, instead of giving it blindly to all the patients, reserve it for recurrence. And I think some data is available here, but all this are old data. and they say overall survival ultimately is same.
So we the radiation oncologists, we call it as salvage radiation, and if we do it just immediately post-op, we call it as adjuvant radiation. So as far as salvage radiation is concerned, unfortunately, when we salvage a patient and when she recurs, it's not easy to salvage. The results are not good, and the overall survival actually does not change. The local control may change, but the results, I don't think salvage radiation would be my choice of treating a patient.
We have some paper where I think you wait for recurrence. In case the recurrence occurs, and you detect them at a very early stage. I'm not talking about big recurrence where the tumor is extending to the parametrium and involving the pelvic side walls and all. I'm not talking about that kind of recurrences. You have to have a very strict follow-up.
So there's always a risk we'll be able to detect only when the patient has a widespread kind of a recurrence, very risky kind of approach. And cervix cancer is very fast.
Maybe it's risky. We don't have a strong evidence for that, but I think there is some data available for that. I don't remember. I don't have the paper with me. Some data is available which says that you can reduce the combined modality by this approach. It's not a standard of care, but I think it's a case.
I think we have the inputs from Dr. I think we have.
Can I?
Yeah, please.
Yeah, see, I have one comment, one observation, and one question. The observation was both the panelists agree that there are certain indications where both agree adjuvant radiation is needed, LVSI, deep invasion, and adverse histology. So I think that will cover most of our problems. We will be left only with tumor size, which we can detect earlier and decide whether we take up a surgery or not. The comment other was that most of these studies for cancer cervix, I think we should not be just relying on overall survival. A pelvic control is very important in cancer cervix for the quality of life. Even if we don't have a change in overall survival, a woman living with a dry pelvis would be definitely much better than having a similar survival with a disease in the pelvis. So I think we should take out overall survival from our overall benefit of adjuvant therapy. We should concentrate on pelvic control also, give more importance to pelvic control for quality of life. And third is the question. The question is that it's 3 decades of this criteria and radiation. But like in endometrium, we had many trials comparing, we evolved from whole pelvic RT to brachytherapy and all that. Here, whether any trials where you thought brachytherapy would be equivalent to pelvic RT, any attempts were made, and will there be a role of, you hear terms about small field RT, brachytherapy, which would give less toxicity and have the same benefit. So anything on that?
Sir, initially in very early stages, brachytherapy alone was also tried, like we do in endometrial cancer. But in trials like this, in GOG 92 trial for that matter, they did not use brachytherapy after external radiation. They only used adjuvant external radiation, and that's it. They did not.
So why not brachy alone? We are treating with the node negative, parametrium negative, only local tumor positive factors. Everything else is negative.
Yeah, so it has been tried in studies in which they have defined local control as in 2 parts. One is the control in the vault and control in the pelvis. So in studies in which radiation only brachytherapy was used, or in studies in which external radiation was alone used and brachytherapy was not added, there was high rates of pelvic failures, that is pelvic lymph nodal failures, and not vault precisely. So hence nowadays we radiation oncologists, we don't prefer brachy alone as far as cervix is concerned. We always give it as an adjuvant after external.
Dr. Abhishek, one comment. Actually, MD Anderson is using the small field radiation in such cases where there is actually the nodes are negative. The parametrium is negative. And once we are talking about the central recurrence, most of the time the recurrence occurs in the pelvis. So what is your comment on this, considering the small field radiation, what Dr. Ahuja has just asked you about? Because we can reduce, we can bring down the morbidity. Of course, we are concerned about, of course, whatever the advances have taken place in the technique is on one side, but can we further reduce the morbidity by considering small field radiation?
Small field radiation, as we radiation oncologists, we are doing SBRT. We are doing very high. We have the technology to deliver very precise radiations at a very precise kind of location in a very reproducible manner. But as far as cervix is concerned, the trials of SBRT or small field high dose radiations, they have failed, and they have failed to replace the dose advantage which brachytherapy offers. So either it is vaginal brachytherapy alone, or I don't think the small field radiation, as you're mentioning, is any kind of, nobody's using it, it's not standard. They might be evaluating it, but no. If I have to use small field RT in brachytherapy, in cervix, I'll rather use brachytherapy than using a small field RT.
No, I think probably what Rama meant was you have a comparison of external pelvic RT where you use a larger field.
Yeah.
Here you have done a surgery and node negative, parameter is negative. You are giving radiotherapy for intermediate risk factors. So instead of giving a large pelvic field radiotherapy, external RT, you give a smaller field.
Small field encompassing what? Encompassing the vault?
Encompassing the vault and the parametrial area.
Just
I think that this was described by Neville Hacker, and he has compared it with brachytherapy, and he says that brachytherapy is actually more problematic in these patients because there is sexual dysfunction. Brachytherapy is going to cause, I think, vaginal stenosis and vaginal dryness. Rather than if you use a small pelvic field, I think the pelvic mobility is much less. That's what I think Dr. Neville Hacker's publication says.
I think I have one more comment. Sorry.
Yeah,
I think yeah, tell me. Yeah, after you.
So when we use a big field, we mean we have to encompass the parametrium, the vault, and the pelvic nodes. And when we are talking about a small field, by which I can understand is we have to include the vault and just the medial parametrium. So as you rightly said, sir, we can do it with brachytherapy and we can do it with small field RT. Small field RT is obviously compared with brachytherapy if we have to do it. Brachytherapy will always have more kind of complications as compared to small field RT, because with brachytherapy we are able to achieve we are able to give a higher dose, and that we are able to do that, and we do that. So it'll have these kind of sexual complications. It will have vaginal dryness because it does. We can also give higher dose by external radiation, but the complication will be as compared to we'll get by.
I want to make two comments. I think from all the review of literature and everything I was doing, I think probably what I found out is that initially SEDLIS was a kind of a big basket, and the intermediate was thrown in that. Probably now it is like you have to pick up certain stuff from here, and definitely feel like deep in carcinomas where you don't give adjuvant have recurred with distant metastasis. So it is very like cherry picking from basket factors. And I think is the idea for this with excellent control in all these patients and with negligible side effect profile. So I think probably we have to use innovations in radiation along with probably cherry picking certain cases to probably get a better outcome for these patients.
So I think one comment.
Yeah.
The only thing is that the criticism against limited RT in showing higher recurrences, which Dr. Abhishek mentioned. I think one major factor was that there was no standardization of surgery in all those parts. So there was limited data. Extent of node dissection was not standardized. The extent of surgery is not standardized. So that's why if you define a standard, what we consider an excellent surgery, as Dr. Bafna is saying now. So I think that will give different outcomes compared to a pool which was being there analyzed earlier.
Yes, and if you compare, if you look at the series from Germany, Hockel series, which I don't know how many of us can believe, total mesomestrial resection being done for stage 1B1, 1B2, stage 2A also, 95% 5-year overall survival rate, no adjuvant therapy, even for node positive patients. I don't know, very difficult to replicate, difficult to believe.
Doctor, I think this Hockel's, I mean to say, technique or whatever you're talking about, this is the era where we have to focus on optimizing how optimally surgery we can do it, and how can we optimize the adjuvant treatment, including the radiation therapy. So what I feel is that the radiation therapy, of course, should also consider the good surgery. there is a background of the good surgery, the standard treatment, how we can modify it. Not many modifications we see in cervical cancer. This is what I feel. So any comment from all, and I think we have Dr. Kanika also and Dr. Neha, your comments too, and then we can, Dr. Rupinder is also here. I think comments from all, invite comments from all. It had been a wonderful session.
So Dr. Rupinder has asked a question, views on re-radiation for recurrences.
Okay.
Very, very individualized approach. A lot of things have to be considered. What was the technique used previously? How much dose was given? What were the volumes used? And how much, the most important is how much time has lapsed from the last radiation. That is the most important thing. And one thing which we cannot document is the suppleness of the tissue. How much fibrosis is there? If somebody comes to me with already she has received radiation, and I do a PV and I check out the tissues, and the tissues are very supple, very less fibrosis, I'll be encouraged to give a very good dose. And in most of these cases, we of course have to limit the external dose as well, because we have to consider the dose which has been given in past, and we have to deliver the brachy component takes a lead. It is more as compared to the dose from the external component, because with brachy component, the dose is very, very limited, very focused to the area where we have to give it. The spillage to the normal organs at risk, like bladder and the rectum, is least as compared to brachy. But at the same time, we have to give external also, because we have to cover the subclinical dose as well. So we have to consider all these factors.
But you compromise on the dose.
We have to sometimes, ma'am. Yes, we have to.
Okay. Do you consider any kind of you can say interstitial implants in such cases?
Definitely, because when we give brachytherapy is mainly of two types. One is intracavitary, and by intracavitary brachytherapy, we are giving it to we are prescribing it to point A. Rather, centrally located patients, tumors are treated well with intracavitary radiation therapy. But whenever there is a high degree of parametrial involvement, like parametrium going up to lateral pelvic wall, then intracavitary brachytherapy cannot throw the dose till that far. So in those cases, especially, we have to do interstitial. And in post-operative cases, where the thickness of the tumor, the craniocaudal thickness of the tumor is more than a centimeter, in those cases, interstitial brachytherapy has to be practiced.
Thanks. So any comments from anyone, and then I think we can conclude. Dr. Neha is there to conclude the session.
Yes,
Neha, thank you so much. And first of all, I think it had been a wonderful experience to really have such a good webinar from your side. And the topics chosen were excellent.
Thank you so much, ma'am.
Excellent speakers, and I think excellent presenters. Of course.
So I wish to thank all our speakers and all our chairpersons for giving us time. And also, even though we have extended time, everybody stayed. And it was wonderful having you here. The idea was to actually include topics which make us think, rather than just presenting data and trials. And this is what we will also take forward. We will take INDIGO forward and try to include more topics, and anyone could volunteer, and we would try to take individual topic and introspect it from all angles, rather than just deciding on clinical data. So thank you everyone from the bottom of my heart, and it was lovely having you here. Thank you so much.
Thanks for the invitation.
Thank you.
All enjoyed.
Thank you so much. Bye-bye. Bye.